Thank you everyone for joining us. Abdel, if we can have the next slide. The meeting's about to start. I just want to run through a few housekeeping points before we get going. Just so that all attendees and speakers are aware, we have live translation services available at the meeting in French, Portuguese and Spanish. Please therefore go into those channels if you'd like to, and the instructions, if you don't know how to do that, will be posted in the chat. Particular point to speakers, therefore, if you would like to speak in one of these languages other than English, please announce which language you're going to speak in so that the translators are aware, and make sure you're selected in that language channel. We've got a really packed agenda, so we're going to be keeping strict time. So if any of the speakers hear a tone played, please do wrap up your presentation so that we can hear from the other speakers today. Just so everyone knows, today's meeting is being recorded, and a link to that recording will be published soon on the co-hosting websites. In the thematic sessions today, the audience, we will be very much encouraging to ask questions, and therefore please use the Q&A tool at the bottom of your screen. People can also upvote questions by clicking the thumbs up icon to make sure that those questions are most likely to be answered by the panel. If any of the speakers have any technical problems during the meeting, please email Abdel. I'll pass now on to our chair, Dr. Gail Carson, to open this meeting for the second day. Thank you, Gail.
Thank you very much to the organisers of this meeting, and thank you all for joining us for day 2. Next slide, please. Thank you. So for those of you who didn't join us yesterday, I'm going to spend the next 5 minutes just giving you an update on the topics and some of the key themes that we covered. But let's, safe to say, we're going to be together today for the next 4 hours discussing One Health and the transmission of SARS-CoV-2. Next slide, please. So some of the overarching themes from yesterday were the following. I think this pandemic, and it was certainly echoed yesterday, has shown us just how vulnerable we are as a world, as an international community, as local communities. We will gain more from greater inclusion, collaboration and solidarity as researchers and funders from all the regions. And it's absolutely super in a meeting like this to see all the different stakeholders come together and to try and agree on what needs to be done. There needs to be equity in funding of research, the process and the peer-reviewed publication, that research capacity enhancement needs to consider local context. And that was a theme that came through a lot yesterday about local context, the local groups, local researchers driving the needs and sharing those needs. That funding is a service. Indeed, we all serve in many of the roles that we have, and not a power, and therefore one to be considered and used very carefully, and ideally in collaboration and discussion with the people we're trying to serve. So yesterday's opening session was super, and we heard from a number of the organising groups, such as GloPID-R, who I also work for. That's a consortium of research funders. And Professor Kaushik, the chair, spoke about a number of our activities, but highlighted, for example, the importance of data sharing and some of the other roadmaps that we've developed and the plans we have to define our COVID-19 research activities for the next 12 to 18 months and funding priorities. From UKCDR, that they're keen to ensure context-specific research, which is clearly vitally important in this pandemic, and they spoke about COVID Circle, which is particularly relevant to these 2 days. Not only that, about safeguarding and equitable partnerships remain their key priorities. It was an absolute pleasure to hear from the boss of Africa CDC, John Nikinsong, and he highlighted many things, but just to mention one, research in the low and middle income countries needs to be responsible and relevant to them. Again, a pleasure to hear from a colleague of mine, Moses Alobo from the African Academy of Sciences, who also outlined how African partners can successfully collaborate and develop, co-create these regional research priorities. Indeed, too little research has been funded to date to understand or support context-specific research priorities in the low and middle income countries. Next slide, please. And so to reflect on the two main sessions from yesterday, the first being clinical research networks and clinical research, we heard from the coalition, who I'm also associated with on their steering committee, who are also an organiser of this meeting, that the voices of active researchers from resource-limited settings must be involved in making decisions about research priorities at the global level, as well as determining the local and regional priorities. And certainly the coalition tried to provide a voice where needed. Examples were given of some of those regional and international networks that have a regional footprint from ALERT and ISRIC. Again, I'm associated with those. It's super to see them develop and grow under, for example, John Amowasi's leadership in Ghana. That intersectoral coordination and greater funding coordination is needed, and this is certainly something that groups like GloPID-R are indeed reflecting on together. Pre-existing partnerships have strengthened the research response to COVID-19, again showing the added value of preparedness, something that's often difficult to measure if you're successful, but clearly is needed and beneficial. Data sharing, despite all the advances, remained a clear barrier for those who spoke yesterday, and that's something that definitely still needs worked on. And that biobanking and rapid ethics review are further areas needing increased coordination, capacity, funds, and indeed political will. And I think the pandemic has shown us how much we need that political will behind the changes we're trying to make for the public good. The second session from yesterday was on health systems and indirect health impacts. And I'm sure you've all been involved with discussions around unfortunate consequences of the pandemic for the population, well beyond that of SARS-CoV-2, for some of the non-communicable diseases. For health data systems, if they're not in place, and many of them are not, for example, to collect data on excess mortality, then we go into and try and drive our way through this pandemic partially sighted. That public perception has been a barrier to accessing health services, but we have to remember what influences public perception. We have a responsibility there. Our communication has to be two-way. We have to also listen and work with. We need to learn from the pandemic to develop resilient health systems. They've all been stretched across the world. And again, that should involve community engagement, because it may involve working alongside the community who perhaps do not require hospitalisation. And some great examples were shared by Dr. Queen Dube from Malawi. That we need further implementation research and social science research on health systems with the integration of research capability, and where we have seen that pre-existed, those health systems were able to run their own research and inform their policy and care. And indeed, there's a need for better communication and ensuring that vulnerable populations are reached and engaged through research. And I would like to put forward that they're held centrally in everything that we're trying to do. And that's that we listen to them too. So thank you very much. I'm delighted to say that we are represented and have the support of the World Health Organization today, so that's super. And Dr. Tedros is unable to join us in person. As you can imagine, he's incredibly busy, but he still took the time out to share this message with us. So if I could ask the team to show the message, thank you.
Distinguished guests, dear colleagues and friends, since WHO's founding in 1948, the global response to health emergencies has been a core part of our mission and mandate, including research. In recent years, WHO has integrated research and development fully into our outbreak preparedness and response efforts, with a focus on lower and middle-income countries. And through the R&D blueprint, we have enhanced the coordination and funding of critical R&D for priority pathogens such as Ebola. These efforts are bearing fruit, and together with partners and many African research teams, we now have 2 vaccines and 2 treatments for Ebola, and their impact is tangible. For the COVID-19 pandemic, WHO convened a global network of hundreds of researchers to assess research priorities, develop methods, and review emerging evidence, which has been used by GloPID-R and other donors to coordinate and guide research investments. More recently, WHO also led the Solidarity Trial, the largest such multinational trial, which generated robust evidence on 4 drugs for COVID-19 and included hundreds of researchers in low and middle-income countries. We welcome collaboration with GloPID-R in close coordination with the WHO Global Research and Innovation Roadmap for COVID-19. WHO remains fully committed to using our convening power to bring the global health community together to develop the accessible, affordable technologies the world needs. I thank you.
Well, thank you very much, Dr. Tedros. And I know we're joined by Anna Maria from the Blueprint team, so I'm sure she'll pass on our thanks. I would like to invite Dr. Michael Makanga as our next speaker. I'm sure many of you know Dr. Makanga. He's the Chief Executive Officer of the EDCTP Association Secretariat. He has an esteemed medical and professional experience spanning 25 years, and we look forward to hearing what he has to share with us this afternoon. Over to you, Michael.
Thank you very much, Dr. Carson, and warm greetings to all our esteemed participants to this webinar. In the next few minutes, I would like to share the European and developing countries clinical trials partnership experience in our response to COVID-19 research in the African region. Next slide, please. Looking at the global picture, as of Sunday, you can see that globally, close to 130 million confirmed cases of COVID have been reported in the WHO dashboard. And of these, about 2.4% are coming from the African region, which is second from the bottom. And this is not to make us complacent. The numbers are on the increase. Next slide, please. Looking at the cases between February 2020 and March 2021, and looking at and considering the new COVID-19 cases that are reported by day in the African region by Africa CDC, you can see the 2 peaks. And looking at between the epi week 8 and 9, the epi curve trends downwards to a level reported in October 2020. However, in the past epi week, you'll notice the curve has begun to trend upwards. The question is, could this be the new variant leading to a surge? This is a moment not to be complacent in Africa. Research and development in Africa is very important. Next slide, please. Why should we pay special attention to Africa-specific COVID-19 research? We need to better understand COVID-19 epidemiology in Africa, to better understand the spread and response. We need to recognize that biological responses or immune responses to COVID-19 may be different, given the differences in the African region. Considering the demographics in Africa, we have differences in age profiles and other potential vulnerabilities, considering the socioeconomic factors at play, and also the high prevalence of other diseases, especially the infectious diseases and the growing incidence of non-communicable diseases. We also know that the control measures that may be applicable in other regions, especially the classic public health responses, may be difficult to practice. For example, the hygiene promotion, isolation, some of the restrictions on movement and lockdowns. And testing may itself be a challenge. We know that PCR is quite expensive and limited. And we need to have affordable and simple to use alternatives in the different countries. And recently we are beginning to see the new variants, the 501 variant from Southern Africa region. And recently in the last 2 days, we've been hearing of the new variant coming up from the Tanzanian travelers. We have issues that are related to long COVID and other things. So with this in the background, next slide, please. I want to observe 3 factors that have been very important on the side of EDCTP as a contributor to the response to COVID-19. First has been the investment in clinical research. By the end of the year, we had activities in 37 sub-Saharan African countries that are involved in clinical trial activities and also in preparedness response. Now, these and the infrastructure from these has been diversified to a large extent to fight COVID-19. The second factor has been, next slide, please. When the problem of COVID-19 hit, almost all countries that are in collaboration in activities called back their research scientists back home to focus on the problem at home. And what has been instrumental is the local scientific expertise and leadership, which has been built through the clinical trial activities that are happening, and also the very proactive training and funding of fellows in African countries that have excelled in their conduct of clinical research and also developing as leaders globally. These are the ones that have taken on the mandate to really help their countries and are the ones serving in the advisory committees nationally and internationally. And what is important here is that these are scientists that understand the local contexts, but at the same time are internationally connected, being able to share information beyond the countries where they belong. Next slide, please. Another area of investment has been addressing the issue of ethics and regulatory capacity. Often this is an area that really delays research response, and an investment in these countries has played a key role. Next slide, please. Now, as a program, we have decided to use the existing resources. First was the investment that we had made in epidemic preparedness post-Ebola. And here we had funded 2 important consortia in epidemic preparedness: the Pan-African Network for Rapid Research Response, Relief and Preparedness for Infectious Diseases, Pandora IDNet, and the African Coalition for Epidemic Research Response and Training. These networks have had immediate initiation of training activities in labs and case management as a point of entry. And they have been involved in characterization of protocols in several countries. And they've used their resources in response to COVID-19. And many of our projects as well that have been working on other diseases have diversified to incorporate elements of COVID-19 response. But specifically, we also put in place new investments. And these included support for now 26 projects responding to different priorities. And also through collaboration with Africa CDC, we launched a call for training of epidemiologists and biostatisticians which is now going to result in training of about 150 candidates throughout Africa. And we also have the investment in the regional networks of excellence, which is responding and contributing importantly, especially to the epidemiology studies related to COVID-19. Next slide, please. Now, I won't label this slide here. It is just showing you some of the thematic areas that have been addressed in the epidemic response activities. Next slide. What you see here are some of the new COVID-19 research activities that are highly collaborative, resulting from the epidemic response call. And what you see here, these are projects that are responding to the local problems, but also bringing in the international collaboration context and have bi-directional capacity development. 12 of these are led from the African continent, and 12 are led from the European continent, and 2 are new. And half of these are led by females as well. So this is a new development that you will see, that in the consortia, you have dual learnings from the north and from the south. Next slide, please. Yeah, this one is just to show you that you will be able to access this from the website. You have detailed information on these projects that are going on so that you have an understanding of what is happening. Next slide, please. Here, I want to very quickly share with you some of the initial feedback that we are getting from the studies that are going on. Clearly, there is a need to improve on the side of epidemic preparedness and community engagement. There is a need to improve health infrastructure, human resources, and medical technology using local resources that will enable the continent to go to another level. But what has been shown fundamentally is that improving the health sector human resource capacity at the primary healthcare level, such as community health workers, have particularly proven to be an effective approach to early containment of the global pandemic and must be prioritized in Africa. Next slide, please. It's important to note on surveillance and response as well, looking at the landscape on the sequencing capacity in Africa, that the use of genomics to support the response to COVID-19 is currently very low, and there is need to mobilize resources to address this, including digital and genomic strategies, and recognizing the potential of the genomic technology and computational power. When you look at the landscape in Africa, you will see that 71% of the next generation sequencers are concentrated in 5 countries. Moreover, 70% of these are found outside national public health institutes. So there is a lot to be done in terms of national investments. Next slide, please. And the feedback on the key populations. Of course, the ongoing studies that are involving risk and transmission immunity in pregnant women and infants. There is an upcoming and increasing risk that is coming up associated with stigma. And this is attributed to the impact of mistrust among the population, and a lot has to be done to address this. There is a need to redefine the concept of key populations in the context of COVID-19, with patients, for example, that have non-communicable diseases, and also some of the frontline workers in the context of Africa that are a little bit different. Police agents in the banking sector, where you have limited digital banking. And these are some of the new areas that need to be given attention. Next slide, please. In the area of interaction with major infectious diseases, part of the feedback has been on the disruption in health services delivery. The increased focus on COVID-19 is important, but this has resulted in decreased care for patients in some of the PRDs, and also the growing burden of the limited programmatic activities. You have increased mortality that is driven by the interruption of the ART for HIV patients, late diagnosis and treatment of TB patients, problems to do with malaria control, and risks that are associated with severe COVID. And this is especially in TB and HIV patients. There is more to this, which will be available in the slides that will be shared with you. Next slide, please, as I conclude. And again, this is on the area of the impact on other diseases. When you look at the case study that has been taken from DRC, where the focus, you have a dual focus on COVID-19 and Ebola, in the same period, the number of deaths attributed to measles have grown substantially. You're having suboptimal vaccination efforts, and then you have all the vaccinations attributed to other preventable infections seriously affected. Now, all these activities need to be addressed, and in the interest of time, I want to really compliment all the partners that we are working with, the Africa CDC, WHO, and all the other national partners and partners that are convening this meeting. Thank you very much for your attention.
Thank you very much, Michael. That was incredibly rich and super to hear and see you reflect on the EDCTP consultation that was just held last week, which I was delighted enough to be part of. And so we hope to share your slides because I think they need to be looked at carefully. So I'd like to now invite Dr. Ana Maria Hernala Restrepo. Many of you will also know Ana Maria. It's a pleasure to have her here. She really has, with her Blueprint colleagues at WHO, played a pivotal role in ensuring that research is integrated into outbreak response. So thank you, Ana Maria, and over to you.
So good morning, good afternoon. As you heard from Dr. Tedros, and you are not surprised, research capacity building, working with researchers in all over the world as equal partners is our mandate, is our passion. So this is what I call this, put this title for our presentation, is called Research with Local Researchers, wherever they are in the world. So this is what people say in meetings like this. I just heard Michael and others raising some of the issues that always are mentioned in every one of our deliberations on how to improve our capacity worldwide to do research. I just want to highlight two things that are really at the core of this conversation that are at the bottom. Resilient health systems and building through global partnerships. And that's really critical that we get into partnerships as equals, with equal respect and with equal commitment to understand the local realities and the local priorities. And at the top of this pile of words is preparing for the inevitable. That was a motto we always have, and now in COVID it has become more and more important. The next slide is to remind ourselves that in WHO, we don't do this because we want to or because somebody tells us to, but it's a historical responsibility of WHO. It's enshrined in the International Health Regulations, the first version in 1951 and the current revised version in 2007. That, as you know, is a legal instrument signed by all the member states. And adequate preparedness for pandemics is a national obligation under the IHR. You also know about the R&D blueprint, and sometimes people say, oh, it's some people that got together in WHO and decided to have a group with a fancy name. In fact, no, this comes from the WHO Assembly, World Health Assembly resolution in 2016, and it was signed and endorsed by the 194 member states of WHO that we need to work to prepare research during the inter-epidemic periods if they exist, or prepare for research during epidemics, and that in the event of an outbreak, we need to shift from this R&D preparedness form to an emergency response plan. That is exactly what we have done during COVID, among other epidemics. This is just a historical figure because sometimes today we amaze ourselves with what was achieved with COVID, and we are also very pleased of all the achievements, but we need to see that this was built on our collective support and experience and lessons learned from the Ebola epidemic in West Africa. And this is just to show that this is one first example of a large epidemic where the times were shortened through collaborations like the phase 1 trials and the BEPCOM, public-private partnerships like the work was done with Merck and Johnson & Johnson and other companies, and also the implementation of randomized clinical trials in the context of an outbreak that was a novelty. In 2015, we have long debates with partners about whether or not it was ethical or possible or desirable to do randomized clinical trials. Now nobody debates that, so we have made lots of progress. In terms of the blueprint, you remember that we have a set of targeted disease, and we think this is important. You have to start with concrete actions on concrete diseases somewhere, because if you just talk about building capacity, but this capacity cannot be used for anything concrete, it will be certainly lost. And as you remember, we were working also on the idea of a novel agent, a new severe disease that now we call pathogen or disease X, and it's COVID for us this year and last year. In terms of where we work everywhere. This is a blurry picture that shows in color any country in the planet where one of our target priority pathogens has been isolated, more than 5 cases. This is a figure we prepared as part of our Microbes and Money report to the World Bank about 2 years ago. So we really have a global perspective that includes, but it's not only limited to low and middle income countries. In terms of progress, you have seen this figure, but I think it's important to see that as a community, we have scientific roadmaps, we have target product profiles for these diseases, the majority, for vaccines, therapeutics, and diagnostics. We have worked on regulatory standards. For example, the emergency use listing is a process that have emerged from our learning and improvement. The regulatory convergence that we have today for COVID vaccines is an outcome of that. We have also made lots of progress in vaccine trials designs and therapeutic trial designs. We set the standards for the minimum efficacy and the lower bound for the vaccine trials. And we also work on, have promoted with other partners around the world the idea of large, simple randomized trials are the option, not large, compassionate individual level use data that will not provide answers, will not reduce the uncertainty. So I think we don't need to convince, I don't need to convince you that we are committed to accelerating research and development during emergency. Even well before COVID, this is the Nigerian Lassa fever experience. 2 points for this group. The first one, it was possible with the leadership of Dr. Chikwe and the National CDC to make an organized plan long-term for Lassa fever in Nigeria. 2, that is important for partners to coordinate. At the time, Dr. Chikwe, the director of CDC, was overwhelmed by all the myriad of offers by about 20 partners who wanted to help. Many of them left soon after, but some stayed. So it is important that we have a commensurate, coordinated approach to our offers of being partners. And number 3, that the number of critical actions were and can be implemented in a short period of time, even working on partnership with a large number of partners. Then there is the issue of the long-term vision to provide opportunities to existing local capacity. So we would like to say more than capacity building. We think we should give opportunities to the existing local capacities. An example is the work that we have done with Professor Muyembe, Steve Huka, and Sawe Mulangu, and all the other colleagues at the INRP in DRC in developing a long-term research plan for Ebola. Now we are working to develop a long-term global plan for Ebola. And I think this is important because it gives the message to all of us in the community.
Anna Maria, sorry to interrupt. What you've got to say is so important. Please, could you slow down a little bit for the translators, because we really want to hear it.
Okay, sorry, apologies. So we have a long-term vision to provide opportunities to existing local capacities. And this example of the research plan of Ebola that was built by and with the colleagues from INRB is an example of what should and must be done. Some of you participated. It was an open consultation. The plan was drafted from them. They were willing to receive inputs, but it was very much driven by them, and WHO supported that effort. And we are moving into a plan for all the countries that are Ebola affected, so they don't receive support only during outbreaks, but we have a long-term plan. So Now, creating a culture of research, that is very important in epidemic diseases. So I told you about the battles about randomized or not randomized, placebo or not placebo. Now, the current status quo is how we move to create a culture of research, how in the face of uncertainty, the choice is randomization, not just giving anything to appear to be doing something. So 4 examples are in this graph. The first one is the Ebola vaccine trial conducted by 99% African researchers that was up to international standards and led to the licensure of this vaccine by EMA, FDA, and several other regulatory authorities. The second point is the collaboration with ALIMA and the shifting the paradigm of the treatment for Ebola patients in the context of outbreaks that have raised the standards with DRC researchers, with DRC doctors, and now the same is happening in Guinea. The third point is the issue of emergency use of the MURI that led to the capacity to be able to do the randomized clinical trial in the Congo under the difficult and challenging conditions of Eastern Congo. And finally, the fact that through these capacities, we have been able now to use experimental vaccines to respond to outbreaks as part of the response, and that this work has been led by the same researchers who work on the trials, by the same local experts and local healthcare workers. And this has led to the possibility in the last 2 outbreaks in Congo and in DRC to start vaccination within a week of the first case being confirmed, and that has led also to a control of the disease in a short period of time. Now, as you know, we are in the countdown. We have already more than 2 weeks without cases, more than 3 weeks without cases, apologies. So I thought that I should say, like in Kiswahili, I learned when I live in Tanzania, apana kesho leo. So it is not tomorrow, it is today that these modifications, these transformations are happening. And I just have here a graph of a ring vaccination, and on the right, what we call the dream team. There were many of the same researchers that went to DRC to combat Ebola. These young girls and boys, these young doctors and nurses are the ones who are making the huge difference today. And I think we should honor their accomplishments with great respect and their courage. So
Absolutely.
and finally, to move on, we talk about community-centered approaches. Tomorrow you are invited to our workshop. We have guidelines, and we think the communities are at the center of all the research. Without community engagement, none of this should happen. So we are fully committed, and even more now than ever, to ensure that anything we do is with the communities, not only in Africa, but all around the world. We also think that the best democratic approach to include everybody and all the researchers is not to have nationalistic trials, but to support global platform trials with researchers all around the world. And that is not equal to bad quality, that's equal to inclusiveness, opportunities, and high quality research that get published in very prestigious journals that answer important questions for drugs that were being used without the sufficient evidence to make decisions about them. So this is the Solidarity trial, 15,000 people randomized until February, is the second largest trial in the world. The recovery trial that involves patients in the UK is the largest. Unfortunately, they have quite a number of cases that allows them to recruit. We are now starting the recruitment for the second phase, but you just see 636 hospitals in 43 countries in the 6 WHO regions, including Africa, Latin America, Asia. It is possible, it must be done, and this is builds the capacity for the future. I think we need to think bigger than just small groups. This is just a slide to say that we are working on Ebola, on COVID vaccines too. I will not entertain too much, but just to say, we started working on the first week, we are working today, and we are working through all the phases with an end-to-end approach. And then finally, and this is an homage to GloPID-R and their partnership. As you know, the one critical challenge in this pandemic is the nationalism, is the idea that people can, that groups of countries or countries alone can end this. But we need to emphasize through these negotiations, to these forums, to these partnerships, that together is the best way. So it's not the ACT prioritized strategy or the global research plan or the GloPID-R research synergies meetings or the convincement of the funders that we should adhere to principles. It's our all-together effort, our constant emphasis on the need to work together. And I just cited Richard Hatchett, that it requires us to be enlightened and brave, that it requires us to be courageous, to stand up to individual efforts or individual institution efforts. So that's all. Thank you very much, Gail.
Thank you very much, Anna Maria. I know that we are running behind time, but I think what Michael and Anna Maria both had to say was really worth listening to and sets the scene for the afternoon's proceedings. I'd like to invite Dr. Patty Garcia to say a few words before we go to the One Health session. Patty sits on the COVID-19 Clinical Research Coalition Steering Committee with me. So Patty, please do share more information about the coalition. Thank you.
Thank you so much. Thank you for inviting me to talk on behalf of the COVID Clinical Research Coalition. So let's start with the first slide. The COVID Clinical Research Coalition was launched. Should I move the slides or next slide, please? Thank you. The COVID Clinical Research Coalition was launched on April 2nd, 2020, with the publication of this commentary in The Lancet. The aim of the 77 scientists, physicians, funders, and policymakers who co-authored this article was to accelerate COVID clinical research in low-resource settings, but not directly by conducting the research as a coalition, but by identifying the gaps and catalyzing research partnerships to answer priority research questions. The scientists, at the point where this commentary was published, have seen that despite the impressive quantity of research being conducted around the world, with almost 600 clinical trials related to COVID registered by the time it was officially being called a pandemic, most of the trials were planned in well-resourced settings. Today, with more than 8,500 clinical studies that have been registered, still most are conducted in or to meet the needs of the world's wealthier countries. Next slide, please. In the past year, the coalition membership has really grown to 205 institutional members, more than 300 representatives from 60 countries, and also with more than 200 individual members whose institutions have not joined yet, but represent about 63 countries. The coalition is divided in 13 different groups that are working different topics, and about 60% of the members are from research and academic institutions, and nearly 1/4 are from non-profit organizations. Just over 1/3 of the members are from Africa, another third from Europe, around 15% from Asia, and another 15% are from Latin America, and we're trying to push that percent up. The coalition has some principles and ask the members to commit to some of these basic principles, really. The first one, try to focus on advancing COVID research where the need is greatest and where not enough research is being planned or supported. The second is to leverage each other's expertise to support research. The third, to promote and implement open sharing of research knowledge and data. And the fourth, to champion equitable and affordable access. In general, our collective aim is to promote dialogue, which is part of what we are doing in this webinar. Collectively facilitate and accelerate actionable research, bring solutions to bottlenecks through collaboration, and to promote the rapid sharing of research findings. Next one, please. There has been valuable work done to identify research priorities by WHO and the AAS with the Africa CDC and other partners, as we have heard yesterday. But within the coalition, the different groups have been working very hard to identify this series of top 5 lists of priority research questions with the idea of elaborate the most urgent priorities in greater detail, and then to catalyze the formation of multi-country, multi-site research collaborations to tackle some of these questions. You can find these lists in our website, COVID-19crc.org. They are available and represent the work on the different coalition groups. Between them, clinical epidemiology, maternal and newborn and child health, social sciences, virology, immunology, and diagnostics. The next steps for the coalition include supporting these and other emergency collaborations to fill the research gaps in low resource settings. It has been a pleasure to at least briefly speak to you about the COVID Clinical Research Coalition, which has co-organized this meeting with the UKCDR and GloPID-R. I'm a member of the advisory board, and it has been a pleasure and continues to be a pleasure to work with all my colleagues all around the world to try to find ways of working collaboratively. We are very happy to see this increased attention to COVID-19 research in low and middle-income countries, and let's continue the discussion. Thank you, Gail.
Thank you very much, Patty. It's always a pleasure to hear from you. And so I apologise for my session running late, but again, I'm sure you'll agree with me, it's full of richness and sets the stage. And the stage is now set for the next session, which is One Health, to be chaired by my two colleagues, Dr. Chun-Ming Roo from the Korean Research Institute of Bioscience and Biotechnology, accompanied with Professor Uma Ramakrishnan from the National Centre for Biological Sciences in India. Over to you, my colleagues. Thank you.
Hello, everybody. My name is Chung-Min Ryu from South Korea, and I'm working on head of infectious disease research center in KRIP. Already mentioned about my full name of the institute. It's a really great pleasure to open the One Health session. Actually, I'm co-chair with Uma. Say hello to Uma. Yeah. Okay. We have about 1 hour, and first of all, I will give the 5-minute brief introductory presentation. Then I will the 4 propounding speaker giving the really great presentation about the One Health. So I hope it's really a great opportunity to give the really great insight what is really important in One Health concept and One Health in COVID-19 in this situation. Okay, can you give? Can I see my slide? Okay. Let me start with the introductory the presentation. In this session on One Health and COVID-19, we want to share the view from the ground based on direct evidence experience. We would like to a brief description of how One Health is important for an informed COVID-19 response and to prepare for future animal to human spillover events and the infection with the pandemic potentials. I will give this one slide. Just I'm trying to give an insight on LMIC and infectious disease. If you look at figure A, this is L networks, which means around the world, there's a 3 L hub, which is from North America and Europe and Asia. So this is a great hub to connect all around the world. If you look at it, the B figure, this is about infectious disease maps, which disease is occurred in around the world. If you look at it carefully, there is empty area in North America and Europe, but another area like South America and Africa and Asia is all around infectious disease is occurs, including COVID-19. So right now, if any infectious disease, especially transmission rate is really high, it's spread out all around the world through air networks. That is really critical. But especially in Asia area, there is a lot of the disease occurs is all the way. There is a lot of example you already know actually. And recently, we also look at the vaccine access map, it's figure C. In vaccines, access is available in North and South America and Europe especially. Some area in Asia, but Africa and South Asia is almost empty. That is really big problems. That's why we must concern in LMIC and infectious disease. Next slide, please. How about LMIC and World Health? In this session, we are really stressed to importance of the One Health because if you look at and if you think of why COVID-19 is really important and spread very rapidly. So we still don't know about the origin of the COVID-19, but many scientists assume maybe bat or some animals transmitted to human beings. So why these things happens? Because any selection pressure like caused by climate changes or human activities, this selection pressure induce virus mutations. Even though virus mutation occur, cannot cause to transmit to humans. Why these things happens? Because certainly human contact was promoted with the animal vectors containing infectious disease like COVID-19. That is why we need concern on One Health. So next slide, please. So here is the question on objectives. How has an One Health approach informed the COVID-19 response and decision-making in your country or region? What is working well and what is missing and need or preventing on integrate One Health approaches? What are the research gaps and what are the lessons learned from the future pandemics in context of the One Health and preparedness? We also want to talk about research that is being conducted or is needed within One Health frameworks. The main questions are, what research is needed now to support policymakers and public health decision makers in this pandemic and prepared for the future? What are the lessons learned from future pandemics in context of One Health and low resource settings? Okay, thank you. That's it for my presentation. And Uma, can you add something?
Yes, thank you so much for that introduction. I think that, I just wanted to reiterate that we use the word One Health very commonly now. It's something which everybody, it's a phrase which everyone uses. And yet it's a concept, the idea that human health is dependent on the health of the environment and animals, both wildlife and domesticated animals. Actually implementing such a concept is, at least in my understanding, very challenging because it is multi-sectorial, it is collaborative and interdisciplinary, and oftentimes, academics, non-academic scientists, social scientists and NGOs, governments, all work in silos. They work separate from each other. So I'm really excited about this session and curious to learn from all of you how, especially in the context of a reactive framework, it's also okay to think of One Health in a preparatory framework, but in a reactive framework, once COVID-19 is upon the world, how have you embodied this approach and framework?
Let me introduce the first speakers. The Professor Basiru Fongfo. I hope that my pronunciation is right. Is from the Cote d'Ivoire. Is of the Africa 1 ASPIRE. Yes. Okay, here. Okay, please, Professor, off to you.
Thank you very much. Thanks to the organizer for inviting me, and hello to my colleague from the African Academy of Science, WAHO, and African CDC. My name is Basiru Bonfo. I'm the director of Africa One Aspire, which is supported by a consortium of funders through the Deltas Initiative. And this consortium is made of the Wellcome Trust, DFID, African Union. And the objective of our consortium, which is among 11 consortia funded that are under what we call African Research Coalition in Health, the objective of our consortium is to build a Pan-African research capacity in One Health. Why One Health? Just to make a very short definition is that how can we, through collaboration, coordination of health intervention, add value to the societal outcomes? And it's very, very important that before we go into that, even myself, when we were trained, we were not trained on a science of collaboration or a science of coordination. So this is what we are trying to put forward. And the example I always give, and if you need to retain something from here, is in terms of public health, what do you lose if you work in silo, or what do you gain when you collaborate with other sectors? So having said that, next slide, please. When we talk about One Health, we talk about collaboration and partnership. And partnership is the bottom line of mutual learning. In One Health, we learn a lot from each other because we share knowledge. And there are three basic and conflicting goals of research partnership. And we tend of talking about science, capacity, but the impact is something which is very, very important. And we need also to highlight most of the principles that will address partnership into the One Health concept. And among those principles, trust and equity are very important to fill some of the gaps like language, culture, region, and sometimes addressing other type of diseases. Next slide, please. So allocation of resources is very important, and those resources are for investment for future pandemics. So today, Africa is struggling thanks to the Pan-African initiative to contain COVID-19 with the expansion of the conspiracy theory. In such context, threats are still endemic and at risk for global health. And the resilience to those threats represent a good model for addressing the next pandemics. So it's very important to learn from what is happening to respond to the next pandemic. Next slide, please. And this conspiracy theory, we live in that, and One Health is essential, as I said, to understand this, and with the influence of public health system and intervention, this can have a current response to the next pandemic. The last slide, please. We have observed with COVID-19 the limitation of the crisis management. And it's very important to strengthen and learn from the resilience of the public health, because we need to understand what are the social science contribution, what are the community and policy contribution, and what type of behavior we can put into that. So to support research in a socio-ecological system is very important. And I just read one concern of one of the participants saying, why always biomedical approaches? So it's time to add to the biomedical approaches some of the issues which can add value to the global health. And the one which is the most important that can save resources is to look at the origin of pandemics in the animals and environment reservoirs, and to continue working on drugs and vaccine for human, but most importantly, to raise the condition of which those vaccines and drugs can be used. And this is where social science has a role to play in this situation. So One Health is not just a combination of the three entities: environment, human health, or animal health, but it comprises the knowledge sharing and learning that can really add value to the knowledge for the global health. Having said that, I would like to thank you for inviting me to this session, and thank you very much for your attention.
Let's move to the next speakers. It's a great pleasure to introduce Hae-Kwon Kim, who is from the Korea, the same country with me. And he is a professor in Chungbuk National University. I'm sorry. He is working on the bat and human transmission. He's a lot of work on that area. Please, Hae-Kwon, off to you.
I'm Hae-Kwon Kim at Chungbuk National University in Korea. So today I'd like to talk about what would be the next phase of One Health approach as a researcher's point of view. Next slide, please. So in my opinion, the One Health approach so far has been the active surveillance of viruses in diverse host species. Actually, with the pioneering researches, we have accumulated many novel virus data in domestic and wild animals. For example, there has been the active surveillance of bad coronaviruses around the world, and some bad coronaviruses were predicted as a potential for the next pandemic before. However, the predicted viruses were not the same as the SARS coronavirus type 2 regarding the recent pandemic COVID-19. I think it's a 50% of succeed. You know, as the viruses continuously evolve, it's very hard to predict the future strains for next pandemic. Next slide, please. So therefore, we need to collect ideas how we can predict the next viruses from the collected virus databases so far, as well as our up-to-date knowledges. So in this regard, I would like introduce basic concept we can keep in mind. As you know, the viruses cannot evolve without host. That means viruses can replicate only inside the host. That means the viruses are only mutated when they succeed to replicate in the host. There may be many mutant viruses after replication, and some of them will be disappeared, and some of them will survive. Then we can give a question: who select the survivors? I think it's the host. Therefore, in the virus world, the host is the nature, and the host may be a selector for the future virus strain, although they are also the victim of the virus infection. You know, it's a little bit ironic. With these ideas, we can make questions if the host condition affect the virus mutation rate. There would be host factors that increase the mutation of viruses so that the new virus strains can be produced with the potential for the interspecies transmission. For example, it's just my hypothesis. In case of bat species, some bat species undergo hibernation during winter season. So when they go to the hibernation status, their body temperature is below 10 Celsius degree. So with this harsh condition, I believe the virus have more mutation than the normal condition. So I think the host condition is a very important factor for the virus mutation rate. So in addition, if the host select the next generation of the viruses, then I think we can expect there are some selective patterns of the mutation by the host. So every virus can infect the host, and some survived viruses can be selected by the host in certain condition. So with these approaches, I think we can catch some selective patterns of mutation site of the viruses in specific host. Next slide, please. So I would like to suggest the next phase of One Health study can be about the principle of virus evolution in diverse host conditions. So before they come to human, we can predict high-risk conditions that increase virus mutation rate in diverse hosts. For example, so certain environmental or ecological conditions can be predicted. Also, even in the interface of animal to human transmission, I think we can also predict mutation sites or patterns that can be selected by human host so that the virus get to the human transmission. Anyway, this is my personal opinion. I think it is time for us to collect new ideas to predict next virus with the collected virus data in diverse host species. Next slide, please. So now is the end of my slide, and thank you for your attention.
So,
Yes.
as I understand it, you have the long history surveillance on bat coronaviruses. So, based on your studies, is there any relationship with the bat and SARS-CoV-2?
Actually, I just surveyed the coronaviruses in the bat species in Korea only. So when we do the surveillance of coronavirus in bat species in Korea, we did found some, SARS-related coronaviruses, but they are a little bit far from the SARS coronavirus or SARS coronavirus type 2.
Okay,
So,
it's
yeah.
a little bit different.
Yes, right.
Okay, thank you.
Thank you.
Okay, okay, thank you for Haekwon. See you later again.
Thank you.
So next, Uma,
I'll go ahead
this is
and
your turn.
introduce, yeah.
Okay, you can go
Yeah.
ahead.
Thanks. I'll go ahead and introduce Jenny. Jenny Hutchinson is at the, she's the deputy head of the science department at OIE. And she's a senior veterinary epidemiologist and executive manager with wide experience in academia, state, and national governmental departments. So she's worked across several countries and continents. And we're all really curious to hear from you, Jenny.
Thank you very much for that introduction. And pleasant though that is, I would like to just let you all know that in fact I'm presenting here today on behalf of my colleague, Dr. Sophie Muset, who is unfortunately not able to be here today. And she is a technical coordinator in the Preparedness and Resilience Department of the OIE. And just for background, for those who are not familiar, the OIE, the World Organization for Animal Health, is the standard setting organization recognized by the WTO for animal health and zoonoses. And in essence, it develops standards that facilitate safe trade in animals and animal products, but it goes far beyond just standard setting. It both informs the research is, it is both informed by research and influences the research agenda with the goal to transform science into practical policy and standards. And when we first discussed your first question about how the One Health approach has informed the COVID-19 response and decision-making, we felt that our EBO-CIRCE project would make an excellent case study as an example of just how the One Health approach really can build capacity and has broad applications and transfers readily in the face of new challenges, as is the case in the COVID-19 epidemic. Next slide, please. So this project, I look at this slide and I realize that it may mean different things to different people. Coming from the OIE and as a background as a veterinarian, I do think of zoonoses firstly from the animal perspective, but of course that's different depending on your point of view. The project was built with an initial objective of reinforcing the capacity and surveillance for Ebola disease in wildlife. Because as we're aware, you know, animals often serve as a reservoir for humans, and it makes sense to become aware of how it's behaving in animals and how that poses a risk for humans, essentially. So this project was originally for 5 years, from 2017 to 2021, but has been extended another 2. It's funded by the European Union and is implemented in 10 countries in Central and Western Africa. And it's the project implementation is led by the OIE, but there are other partners right there. It has 3 key objectives, which are research objectives to ensure that knowledge is gained to, as it says, improve early warning and prevent viral hemorrhagic fevers. Initially, the focus was Ebola, but after intensive consultation in country and between countries and with priority setting exercises, it was recognized that what was desired by the communities they were working in was work in more than just Ebola. So we have a list of 5 viruses that are the listed: Ebola, Marburg, Rift Valley fever, Crimean Congo fever, and Lassa fever. Next slide, please. I should mention that the choice of country where this project would be implemented was informed not just by previous cases of Ebola or even by where the bat habitat is, but also because there's a history of solid partnership in country, because those key connections within and between organizations and people was truly important for the success of the work. Sophie wanted us to recognize that you have to look at more than just sort of the molecular side of things, that in fact it's important to consider all aspects of the disease and the communities. We have people and partnerships ranging from veterinarians, medical doctors, ecologists, anthropologists, socioeconomists, economists, national laboratories, research institutions, veterinary services, national parks and reserves, non-governmental organizations and international organizations. The multidisciplinary approach and the building of teams between all those people has been crucial to success, and building of the capacity, next slide please, was hugely successful, because when COVID hit, we found that the laboratories, the researchers, the key stakeholders were easily able to translate their experience and abilities from project activities directed over to the COVID response. And that, I think, right then and there is a success story, how the years of work in building capacity in country, working in areas that are important to country, reaps immense benefits. And again, this has been a successful project for the communities because it's fed back the results immediately, raised community awareness, has improved surveillance, and has built capacity. Next slide, last slide. And thanks for your attention. And I would strongly encourage you to visit the website or contact my colleague directly for more information about this project. Thank you very much.
Thank you so much, Jenny. That was really interesting to hear about partnerships first, before research. So we'll keep questions for the end, if that's okay. And we'll move on to the last speaker. We are very happy to have Dr. Vaisna Duong, I hope I've said your name correctly, who's an MD PhD and works at the virology unit at the Pasteur Institute in Cambodia. He's the deputy head of virology since 2014, and his main research focus is on arboviruses and zoonotic viruses. So we look forward to hearing from you.
Good morning from Cambodia, and good afternoon from people from Europe. Next slide, please. Thanks, Uma, for the introductions, and also thanks for the invitation to this important meeting. I'll take this opportunity to present an example from Cambodia in the framework of One Health, and I think it is true also perhaps to other countries in other low middle income countries. And what I'm going to present is very complementary to what Dr. Professor Hee Kwan presented earlier on how we monitor the virus on the lab side. But here I would like to stress on the real world side, how we monitor and monitor the virus and how we be able to be prepared for the next pandemic. Next slide, please. I would like to start the presentation with this very typical photos to show and remind us again the different interfaces and how people us go into contact with animals and also viruses and other pathogens carried by these animals. And also to remind us also that these interfaces between human and animals does not present only today, but it will continue to be present in many years to come. Next slide, please. And this important diagram showing, this is also to remind us that we are in constant interface between these domestics and wild animal and also other vectors. And these animal and vectors carry their own pathogens. And it is us humans that put ourselves into risk for the spillover, and showing also the importance of One Health surveillance that may help prevent and also help us prepare for the next pandemic. Next, please. And we also know that emergence of pandemic potential viruses and pathogens can be everywhere. It's not specific to any countries. For instance, Ebola, swine flu, SARS-CoV-2, MERS coronaviruses. And example here, we have the emergence of the virus of SARS-CoV-2 in Yunnan, China, but our recent work from Cambodia and also from Thailand recently, showing that the virus, the ancestor of the SARS-CoV-2, may present in a wide range of geographical area, stretching from southern part of China to Southeast Asia. And this finding provide us also the opportunity to look for secondary hosts that may help the virus to jump into humans. And next slide, please. And here is to take our attentions that we are at the moment too much into COVID-19, but we need to be reminded also that there are many other pathogens, especially viruses, that are at different interfaces and waiting for their time to cause the next pandemics. And I would like to highlight here a different interfaces that is present in Cambodia and also in other parts of the country in Asia and also other low and middle income countries. For example, here, the bat guano farm that just perfectly show the interface between the bats hanging on over the trees and those domestic animals and humans walking under these bat roofs, exposing to the guano and the urine. Next, please. Another example of rodent traits, putting humans into contact with rodent pathogens, for example, here, and hantaviruses that are circulating, we found circulating in those rodents. These rodents are collected from different parts of the country and are transported through these trucks or motorbike, hundreds of kilometers to a border to sell for consumptions, exposing a lot of people along the food chains into the infection of rodent-borne disease. Next, please. Another example, this is well-known Nipah viruses that are endemic in Asia and are known, and therapeutic species, especially flying fox, are known to carry this virus. And just an example of the interface between Nipah and humans here. In the photo show a regular routine or daily basis of a village where there is a morning market just right under the roost of hundreds of flying fox carrying Nipah viruses. If the photo on the top left show, it's not clear, but showing the urine dropping while these flying fox flying over these morning markets. And just imagine that a world with the pandemic of these Nipah viruses with up to 60% of fatality rate, we might see a different phase of pandemic comparing to this current COVID-19 pandemic. Next, please. And this is the last example of the interface that we know already for a few decades, and a lot of surveillance have been put in. A lot of surveillance effort have been put into the surveillance of this influenza virus. And here we show the typical live bird market present here in Cambodia and also other Asian countries. People are working very closely with those poultries, exposing to any potential avian influenza viruses that are are able to mutate it very well, and at some point this virus may just have the right gene to infect humans and to cause a pandemic as well. Next, please. And all these example that I showed you earlier is to show here how important a coordinated One Health surveillance strategy is very important for the preparedness for the next pandemic. And this is not new, but it's already implemented through predict programs through the last 10 years. And unfortunately, this program has ended just before the pandemic started. And this is an important One Health surveillance strategy by looking at community at high risk where there is interface between animals, humans, and at the same time looking for acute patients in order to identify any spillover events in those communities. And on the top of that, there is a study to understand the behavior risk of these people living in close contact with humans. And through this long-term surveillance program, a lot of advantage or a lot of benefit have gained through this program. For example, we have implemented One Health surveillance by taking humans and animal sector to work together, strengthens lab capacities throughout different countries across the world, biobanking of a well-characterized and sample from humans, from animals. We also built a large laboratory network that we can help share knowledge, share data, share samples for further characterizations. We quantify risk behavior among people living in those areas. We also help characterize different viruses circulating in those interfaces, communities, and all this information help public health stakeholders to be able to control any emergence at the source by through early detections, containments, and mitigations, and all these finding provide an evidence-based interventions measure that help reduce the risk of exposure and also potential spillover of different viruses. And also all this biobank can provide, and characterization would provide any potential candidate viruses that help vaccine and drug development for the preparedness of any emergence. Next, please. And this is my last slide, and to show a perfect and ideal One Health surveillance that have been implemented for influenza viruses. And I think it is important for us, the presentation by all the blueprints have shown that there is a potential candidate for the next pandemic, and we just make our bet on any viruses with pandemic potential. And what is important to do is to invest on that candidate and provide a long-term investment in different low and middle income countries to be able to be prepared for the next one. And with that, I thank you for your attention.
Yeah, thank you so much. I think that it's really great to hear such an interesting perspective. I think we'll take the first question, which is, what are the significant barriers or challenges in driving a One Health concept in response to the COVID-19 pandemic? And especially also a question there about funding. So maybe if we could go through and have responses to this from each of the speakers, maybe in the order they spoke, that would be wonderful.
Yeah, thank you very much. The main reason that I can highlight here is Basiru Bonfo speaking, can be first, the resource allocation to sectors that could have added value to the response. Because all resources in Africa, if we look, were channeled to the public health sector. And there are sectors which were not bringing their input, what we say, proportional to their knowledge. The second issue is that we fail to understand that One Health is not just collaborating, but also sharing resources. We have good molecular biology platform in the veterinary sector, which should have been used by the public health sector. But without the collaboration, this was not used. And the third reason is that the paramedical personnel can also help a lot. And we have seen how it has worked in most of the country. I have the experience of pushing in some of the country, Ghana, Tanzania, Cote d'Ivoire, our fellows, PhD and master fellows, to be part of the task force to make contact tracing, even if they are not at originally medics. So let me stop here. Over.
Thank you. Professor Kim?
Actually, the main problem of the One Health concept to the research field, the main barrier is the ideas, I think. We all know about the One Health concept. Animal health and human health is important. We are together on Earth, right? But with One Health concept, then how can we expect or predict the viruses for the next pandemic? It's very difficult. I think we need to collect brilliant ideas to overcome that obstacles. So anyway, many governments and researchers and people know about One Health concept, but the One Health in practice is another problem. So we need to catch some ideas to predict the next viruses. And today, so I just introduced my idea about the host factors. So this is one of my idea, and many researchers around the world can make another new brilliant ideas. So we have to collect that ideas together. That's my opinion.
That's a great response, and maybe I'll add another idea that I had in the end after we hear from Jenny and
okay.
Jenny?
Thank you for the opportunity to contribute. There have been great answers so far. For me, I think the biggest barrier or challenge is operationalizing the concept. I think we all agree on the value of the concept, but how do you make it work? Who drives, who leads, who has the money, who has the responsibility, who can make decisions? Sorting those issues out, even on small projects, takes time and is far more difficult than you'd first imagine. So, at a global level, just as hard, even harder. Thank you.
Yeah, that's a great point. Thanks, Jenny. Go ahead, Dr. Duong.
Yep. That's my experience, and what I would like to share also is that the One Health concept is for some part of the world is quite new, and we have also learned a lot of stories that the difficulties of implementing One Health approach by involving multiple partners, and it is the difficulty part of that concept because different people have different opinions, and as mentioned earlier by Jenny, is that people want to lead, and we don't have a really well coordinated body that can manage or coordinate different partners and sectors to work together. But we do also hear some success story that are able to bring people to work together, especially what I experienced here in Cambodia throughout PREDICT programs. What is limited here? What is I find here the limitation of One Health approach is that it's not sustainable enough. We have funding for a few years and it's ended. It's not. I mean, the sustainability is a huge gap, and it's important that we have to maintain One Health approach on specific area that for long term. So we can be able to understand better the pathogens that we are studying and understand better also the people living in close contact with these pathogens, and also have right tools for detections, for prevention, for preparedness. And this is what I see is the gap, the sustainability of One Health surveillance or approach. And also, what is also important, also there's a lot of finding in the field, and there should be a link between field research, field side research, and basic research. What we find, we discover in the field that can be studied further, characterized further during basic research, like what Professor Haiknon just mentioned, that inject the finding, the new viruses, the new pathogens that are detected in the field, go to the lab and to study further, characterize further, and can be used for vaccine candidate or for drug research approach. That's all for me.
Thank you. Could I add a point maybe? Is that okay? So yeah, I think that, one of the things I'd like to bring up also is the importance of ecological research, because in some sense, when we just lump, species interactions into a bin of high risk interfaces, I think these high risk interfaces also are changing, and that depends on extraneous drivers like climate, habitat loss, and so on, which forces different species of bats or rodents to interact with each other, creating new communities which didn't exist earlier. And those are all ideal, situations for spillover. So this brings us squarely into the realm of basic science and fundamental research. And I think that in some sense, when you think about, outbreak preparedness, that seems like a very applied domain. So I guess I'd also be curious to know about, but that's the backbone. Understanding the wildlife reservoirs is really the backbone in some sense. So I'm curious to know about your opinions on this as well. The role of basic research and understanding ecology in One Health research. Anyone who'd like to take a stab
Yes,
at that?
I can come on that. We tend to push a lot on the ecology and the spillover, which is very, very important. But when you look at the lifestyles and how people consume food or prepare food, the cultural aspect has a very important aspect in the spillover. It's not only having viruses in the birds or wildlife. They are there, but who gets in contact to those environments and why? And if you don't answer to the question why, you will not fully explain why the viruses spill over. Because some people are struggling to get food, like hunting and eating or having different type of habit, including food with domestic animals. So those are the area we need to look at. And that's why the social science and anthropology are very important too, to add to the knowledge on the ecology. And this is what we call the socio-ecological system of health. Thank you.
Thanks so much. Some other questions? I guess that's it.
Yeah,
Go
I
ahead.
can
Is
say
there
about the bamboo viruses.
Go ahead.
So actually, there is a concrete evidence of the, a virus spillover from bat species. The example virus is a Nipah virus. It's fully demonstrated. But in case of SARS coronavirus type 2, we don't know the exact origin, because only the similar virus was detected from that bat species, right? So I think we don't have to focus on the bat species only. On Earth, there are many wild animals, and they have their unique ecological relationship. So I think most the virus surveillance is done by the virologist or microbiologist, But when I'm talking to the ecological experts, they just gave me very good insight for the next study. For example, in case of bad ecologist, she just talked to me about the ecology of bat species in Korea. And as I talked before, the bat species sometimes get into the hibernation during the winter season. So during the winter season, their body temperature is very lowered, and that kind of host condition make emergence of mutant virus much higher. So that is the one kind of expectation we can make. And sometimes I'm wonder also, there is a bovine coronaviruses. Bovine coronaviruses is very similar to the human coronavirus, OC43. They share around 98% of nucleotide identities, but we are not infected by the bovine coronaviruses, right? So nucleotide identity itself is not the key factors for predicting the virus infection to human. So anyway, predicting the new viruses from wild animals, I think it's very difficult. But one point we can approach is that we can survey the human samples in the animal to human interface. Some viruses from animals can infect human and sometimes disappear, but sometimes they can adapt to human and go into human to human transmission. So with that kind of approaches, I would like to suggest to do the active surveillance of human samples. So I suppose, I hypothesize that some human samples may have some new viruses we have not recognized yet. And that's my opinion.
Yeah, thank you. There's one more question in the chat. Dr. Chungming, do you want to read that out or?
Yes. Actually, this is a very long question. Actually,
I can summarize it. I can summarize it. But basically, the idea is that, sometimes collaborations don't just happen on their own. And a lot of early career researchers often feel ignored and are not given responsibility. So the question is, how can we ensure that early career researchers are also involved in these processes? Can granting or funding agencies mandate this? Because this would be good for the community as a whole, because sometimes, especially when you're talking about collaborative research like this, a lot of it is people contacts, and the earlier you start learning about these, the better it is. So I don't know, maybe Jenny, you want to take a stab at this?
It's a question dear to my heart. I was just wondering how much influence I might have in that area, possibly not a lot. On the other hand, in my role at the OIE, for instance, we do are looking at how we choose our scientific expertise, geographical balance, gender representation. It is not impossible to suggest that we should also be aware of early career versus late career. I mean, so it is possible for that policy to be implemented, but people have to become aware that this is an important thing, so that it could be considered. Personally, I think it's a great idea, but over to you.
Maybe if I can add something on that, to bring young researchers or early career researchers, what we are trying to do is to start from the academia on the curricula, taking into account the system thinking. It has to start from there, because when they have this type of system thinking, they will be able to address questions from different angles. Being a medics, you can ask sometimes social science or economics questions or ecological questions. So this is what is lacking in the curricula we have, or we have been using so far. So One Health to move forward need a real capacity building and a real change also in the way the next generation of physician, veterinarian, or ecologists are trained. Over.
Thank you so much. I think that's a really excellent point, and that's something which plagues a lot of probably solution-oriented approaches we'll need to have in the future, whether it's for climate change or the large challenges that face us. So I guess we are almost out of time. Is there anything anyone would like to add? We have a couple of minutes left.
Yep. Hello.
Go
yeah,
ahead.
I would like to add to the question earlier about early career trainees or research fellow. To me, in low middle income countries, the issue is perhaps earlier than that is for young researchers or for emerging researchers in infectious disease field to be able to find or to get a credit to be funded at the first place. This is a hard issue that the issue, I mean, the interface, the problem, the candidate virus is present in those low and middle income countries, and there are researchers there, but lacking of credibility through publication, etc. It's already hard for them to find funding. Not taking account to train others. So I mean, here there is a lot of opportunity to train people and to put young people, young researchers, brilliant, motivated people to be in charge of projects. But the difficulty part is to get funding in this part of the world.
That's a great point. Thanks for bringing that up. You know, I mean, India, 70% of India is below 35. So there's a lot of young people, and I think that incorporating or allowing younger researchers to join in would be fantastic. So Dr. Chung Ming, would you like to add something before we close?
No, actually, I also think of about education, because we are talking about education for young generations, but I also think the education for general peoples, because especially low middle income countries, there's a lot of people just I mean, open chance to contact with the animals. So I mean, they don't know about how important, how dangerous. So I think we need to certain system to educate those people what is important, what is we need to avoid, and something like this. Those are very simple education system also required for preventing or contact is pandemic viruses in future. So that's also really important point, I think. That's it.
Thanks very much. Thanks to all of our speakers and the organizers. I think that was a very interesting session. I hope all of you agree. And we're happy to hand it over to the next session.
I'm Professor Rui Maciel I'm Professor of Medicine at the Federal University of São Paulo. And recently I'm Director of Health Research at FAPESP. FAPESP is the São Paulo State Research Foundation. And I have the pleasure to co-chair this session with Professor Francine Ntumi from Republic of Congo. Francine, would you like to give some words, please?
Yes, thank you, Professor Rui Maciel. Yes, good morning, good afternoon, and good evening, everyone, wherever you are. And yeah, I'm in Brazzaville, Republic of Congo, and I'm leading the Congolese Foundation for Medical Research. And I'm also member of the Clinical Research Coalition, and also the coordinator of Pandora Network, whose goal is to strengthen preparedness and response to infectious diseases outbreak. And I'm very pleased to co-chair the session with Professor Rui. And just, Prof. Rui, I would like to give some words in French. S'il vous plaît, bonjour à tous ceux qui sont francophones. N'hésitez pas à poser des questions. Et puis, bon, la traduction sera là où je pourrai traduire, mais soyez actifs. Cette session est pour nous tous, même les francophones. Merci.
Merci beaucoup, Francine. So in this session of transmission, we want to share views from the ground. And I'm very curious to learn from the speakers. And our first speaker is Professor Esther Sabino, who is the director of the Institute of Tropical Medicine at the University of São Paulo. Please, Esther.
Yes, thank you. So I'll try to be brief and just show the experience we had with our project that is a FAPESP MRC initiative, and with some universities in UK, especially Nunufaya from the Imperial College. So when we first, during the Zika epidemic, I learned this new technology that's nanopore, and we sequenced the virus. But the problem was that we could only publish this 1 year later when the epidemic had finished. So we were trying to develop technology that could help and respond as quickly as the epidemic started. So when the COVID arrived, we were prepared. We had tried to develop more cheaper ways of doing the sequence. And when we did it fast, it came out in all press in Brazil, but which was important because a lot of people learn about science, and the outreach was important for the beginning of the epidemic in Brazil. But more important than that, we were also able, in less than 3 months, to test and understand how it was spreading in Brazil. And actually the 2 main lineages took over the epidemic that's now known as B1128 and 33. So besides that, as we prepare more people and we increase the number of students that learn how to do the sequence, we could also respond when the first epidemic arrived, when there was this resurgence of the epidemic in Manaus. We could quickly sequence and learn that there was this new variant that's called P1 with several mutations. And with the sequencing hands, we could also develop a PCR and learn as early as middle of February that many regions in the southeast country was already have a huge epidemic with this new variant taking over. The second experience I want to share is how we understand the attack rate. And we thought of using blood donors as a tool, especially because I've been working the past years with blood donors. And the problem is the bias that when you try to do seroprevalence studies, it may happen when you use the donor. This is just a view of where the blood donors come from the city of São Paulo, and they are not homogeneous. So if you try to do a study just using consecutive samples, you might not well explore how the virus is spreading in specific cities. So what we did, we developed a system to collect the data and choose the samples in real time. So this help the people in the blood centers to choose the sample and test, and also this system would collect the data and centralize so we could analyze. I think most of the people saw this was a paper published in Science about Manaus, but actually we've been working with 8 cities in Brazil, and this is the prevalence now as of December. And the key thing is that we might now change to new serological tests. They might give us also the idea of what's the proportion of the population that's immune as the tests improve, and we might have a better view of what's going on in Brazil in this next year. The third experience that I think is important that I would like to share was what happened in a city nearby the metropolitan region of São Paulo, that's São Caetano. And early on in the epidemic, this is a rich city, they wanted to do PCR in our institute. And we offer, instead of just doing the PCR, let's promote and organize the response in the primary care setting. And this was a software that controlled each step of the response. So people would come, say their symptoms, everything would be recorded in that system. Someone would go to their house, collect the samples, perform PCR, and then the physicians would follow, everything controlled, centralized. So as it shows in this figure, we have a good view of what was going on in the city all over the epidemic. And we could know what were the most common symptoms in the primary care units. And also now this allows us to better understand the P1, since the city is now having a huge epidemic with P1, we might better understand the impact of the disease and also the effectiveness of the vaccine. So this kind of tool might help us understand and complete our follow. So again, all these studies only possible when we have a long-term support, just like the REDS project, more than 15 years, the MRC FAPESP initiative, and a lot of people and a lot of collaboration. Thank you.
Thank you very much, Esther, for your nice presentation. And let's move on for the next presentation. Professor Christian Happy is the director of World Bank-funded African Center for Excellence for Genomics and Infectious Disease in Nigeria. Professor Happy, please.
I will just take very quick few examples and very quickly to show, for instance, how we've been able to use, genomic as a way to characterize, and do surveillance of microbial threats across West Africa. The first one has to be how we transform outbreak response, using the Ebola epidemic in West Africa in 2014. Before then, the genomic was not a tool that was used for outbreak response, but we did in 2014, 2015 in Africa, within the first 3 weeks of the outbreak, we generated 99 full-length genome sequence and made it openly accessible. So we basically just set a new paradigm, which was open data access, and we're very glad that that has become the standard. And we did it not only for the purpose of publication, but actually to show that you could generate it and share with the communities. And then we came up with new protocols that were able to enable us to have data deposited in GenBank within 10 days. And this is for whole genome sequencing. From data collection to deposition, that was really unprecedented. But then apart from that, we were able to see how we can use that as a way to guide public health response. We showed in the case of Sierra Leone, for instance, that there was no human-to-human transmission using genomic data. But more importantly, this is how we use the first time, you could see here over space and time, how we were able to use genomic data to characterize the spread and then transmission, across the region. So, and this really was the first time where we could use real-time genome data in order to show transmission and spread of an outbreak, over time. And this really was incredible. And this is how we've been able to do this subsequently to express, this. We went further to actually translate this genomic data into developing the first RDT for Ebola in West Africa. And then this is really, and that was a first generation test that was approved by the USFDA and the WHO. So, and then the other example I will talk about is how we were to transform the field by using genome data sequencing, by sequencing a virus that was discovered in Nigeria 51 years ago. 10 years ago, there was no diagnostic capacity in Nigeria. We actually set the diagnostic capacity in country and then do also the genome sequencing capacity in country. Between those 10 years, because of the genomic capacity and sequencing that we were able to develop, we've set up the largest genome data set for this Lassa virus. And then this has resulted, as I'm talking to you, to a clinical trial of 3 vaccines in the continent. So we'll be able to also to develop a rapid diagnostic test. So I don't know, this is where I was, and I was showing a first case study for Ebola, how we were able to use genomic data for the first time to show transmission spread, and then during the West African outbreak in 2014, 2016, we've developed this system, and it's basically what we're using in many countries in West Africa, creating dashboards of this nature, and especially in Nigeria. So the other thing I was saying is that we use genomic data, but we translated genomic data into tools. And then one of the tools that we did for translation was the development of a rapid diagnostic test from genomic sequences. And this test was a 10-minute test and was a first generation Ebola rapid diagnostic test approved by the WHO and the USFDA. So the other thing we did was to use next generation sequencing to generate the largest catalog of Lassa virus sequences. And generating this catalog not only gave us a clear idea of how old this virus was. On paper, this virus is about 50 years old, reported 652 years ago, but in real time, using the most common recent ancestor, the virus is about over 1,060 years ago. Old, was circulating in Nigeria for 600 years before moving out. But we eventually also use this as a way to not only generate a genomic sequence data, but we also translated this into developing point of care diagnostics. And this is a pan-Lassa rapid diagnostic test that we developed. And we had this published in Nature. But what is important about this is that the sequencing of this virus has led to a development of a vaccine. So now we have like 3 vaccines in clinical trial in West Africa. And this was only possible because of the genomic sequences that we did in West Africa. So the third case study that I will mention here is the fact that we've been able to use microbial metagenomic in clinical samples. And that really opened the way to pathogen discovery. So this is a case in Nigeria where we did that in pools of patients who presented with fevers of unknown origin. And we discovered 2 new viruses called the epomavirus 1 and epomavirus 2. And these are rhabdoviruses that are very similar to a virus discovered that was responsible for an hemorrhagic fever in the DRC. The virus in the DRC was called the Bakongo virus. So fast forward to COVID, we were able to use genomic sequencing or next generation genomic sequencing as a way to, first of all, identify or sequence the very first genome of SARS-CoV-2 in Africa. And we did this on between March 4th and March 6th in West Africa, in Nigeria. This was unprecedented, the speed at which we generated this sequence, 48 hours, and made a report available by the 72 hours. So really showing how we could use this. We've gone forward to actually map out the epidemic across Nigeria. You can see all of the 37 states in Nigeria. We know the different lineages that are circulating. We know that in Nigeria at present, we have 55 different lineages of the virus circulating. And we have 3 variants of concern, based on our data. We also came up, with a very nice kind of dashboard that can enable us to see the spread and of the viruses, the different lineages, the 55 I mentioned before, spreading across Nigeria over time, as you see on your screen. And this information has been very, very useful to the National Public Health Institute and the authorities in order to respond. Finally, I will talk about the discovery of the new variant that we found in Nigeria. This is it has become a variant of concern. This is the B1525, and then it emerged from Nigeria and then spread across different countries in the world. So we know today that we've done this epidemiology in Nigeria. We know this variant and the B117 are the 2 most, are the 2 variants that are spreading most in the country. So, but what we do with this data? We actually use this as a way to create what we call a point of care rapid diagnostic test that is done at room temperature. And that can be done, detect samples on saliva. So this also has been approved by the US FDA, but we have 2 versions. This is a point of care like a pregnancy test, but this is a nucleic acid-based test on a paper strip. So this is pretty original. And then we also have the plate version that can be actually be looked upon at that level. This is basically giving you the first assays that we did, the validation. You could see the result here in Nigeria. But then that really also provides the potential to use a CRISPR. This is the gene editing approach. We usually use a CRISPR-Cas13a as a way to do that. That gives us really the power to see that we could actually identify many other viruses using the same approach. This is a case of dengue in saliva. And then we also have the ability now to multiplex all of these. And we can actually identify up to 400 different pathogens in one single assay. And that's really is one new tool we call it Common. So this has been published in Nature recently. So, and then to finish, so through this program and through the tools that we have developed, it is clear now that we've set up a new program called Sentinel. And this Sentinel is an early warning system to preempt pandemic and to guide pandemic response across the globe. I'm doing this with my colleague, Paddy Sabedi. So, and it is built on 3 major pillars. The first is to detect, that is to use genomic technology to develop point of care, as I mentioned, and also develop technologies like coming in hospital and then having genome sequencing in genome centers. That is to detect known and unknown pathogen quickly. Then also use information technology to connect this information very quickly to the public health institutions. And then also thirdly, the third pillar, which is empower, that is empower frontline and public health communities in order to respond to pandemic, because we realize that these are the things that are missing in this space. So at this point, I really want to thank, acknowledge your funders and my lab and the collaborators, and then thank you all for giving me the platform. Over.
Thank you very much, Christian, and happy to hear you. That's a long time. So I'm pleased to introduce Dr. Laurence Baril. She's working at the Institut Pasteur in Cambodia. So the floor is yours, Dr. Baril.
Merci beaucoup. Bonsoir. Welcome, everyone. So from Cambodia, it's a great opportunity to share what we have done so far with all of you and to have also your feedback. Next slide, please. So in Cambodia, very early on, like other country in the region, the government took the decision to close the country and to to take the time to understand what was happening. So everything was put on prevention. The healthcare system here is quite fragile. And so it was really screening at entry in the country. However, we have had 3 community events, 2 in November and 1 ongoing now. Those 3 community events are all linked to people that did not respect quarantine. Otherwise, the population here in Cambodia was really, go with the effort and the recommendation of the government. Only a very few people did not. So at the moment, we have a community outbreak here in Phnom Penh and several other provinces. We do not have a lot of laboratory confirmed cases so far, but 85% of them are relating to the ongoing events with B117 variant. As I said, is a single importation, and we know the index case did not comply with the quarantine measures. And since 2 weeks, we have 10 deaths for the first time from COVID in Cambodia. So Phnom Penh is considered in scenario 2 for WHO, the rest of the country still in scenario 1. Next slide, please. So what has happened is that the Institut Pasteur du Cambodge was the only laboratory for a couple of months in terms of molecular biology, and now we have the National Institute of Public Health as a second laboratory, and we hope soon to have a laboratory able to support based in different provinces. Some are already with gene experts, but it's limited in terms of capacity still. So this is our effort at IPC over the last months, and you see that we have had to transform our virological laboratory in 2 sections, one section for PCR and another continuing our research effort, because we are a research institution as primary mission. Next slide, please. So on this slide, I have tried very early on to summarize what could be our research activity at the Institute here with all our different partners from different consortium. Dr. Vesna presented to you PREDICT, and we have other consortiums that we have tried to activate. And of course, we are part of the Institut Pasteur National network too. So in green, I put by this time where I was thinking we would be in our comfort zone, the mechanism of emergence presented by Vesna earlier. Also, I was thinking that we will be able to do quite easily some serological study, but in fact, here the National Ethics Committee did not approve them. We have tried with different kind of protocol to work on that. It was not possible. We were able, however, to do work with our people from working in the environmental sector, veterinary sector, One other point I was thinking we could maybe be a little bit stronger. It was data information system, but in fact it took some time to harmonize at a national level all the system. We have also, of course, contributing a lot in public health effort in terms of lab framework. I have put in blue what our institution was not really able to drive first, but however, we would have loved to collaborate with people on. And I would like to say that, for instance, epidemiological surveillance, contact tracing was very, very good in Cambodia, still very good, because, you know, the Cambodian CDC is driving very well with the support of WHO. But for social science and the question, it took some time. And I'm not sure we are addressing still very well around the vulnerable population. And also, I'm wondering if we are addressing well the response in terms of access to care. Next slide. It's just to show you, thank you, all what we are doing through the fact that we are hosting the WHO Global Reference Laboratory for WHO, and of course we have to make a lot of efforts in sequencing at the moment, and we would love to join some other consortium to be more solid. I would like just to say that Jung Vesna is now head of virology since August, and no more deputy head is Dr. Eric Carlson, who is our deputy head. My last slide, please, is just to emphasize that we should not concentrate everything on one epidemic, on one pandemic. This year we had influenza, seasonal influenza epidemic, and maybe one of our derivatives from virus will be used for the next vaccines for the North Hemisphere. It has been selected by WHO. We have had also chikungunya epidemic after 8 years without any epidemic that was very difficult for adults, and of course dengue this year, and we have tried not to close our activity on rabies with the prophylaxis, post-exposition prophylaxis. These are just examples of continuity you have to secure for your population. Last slide is just to show you the contrast, of course, in a country like Cambodia. So next slide, please. The last one. Is a contrast between what we can do at a lab level or on the field with our research and the reality of a big part of the population. And I'm just asking myself, you know, how we can continue to help the population living in rural area or in the peri-urban areas that are population, you know, at high risk during emergencies. Thank you very much.
Thank you very much, Dr. Barry. And now, and you have addressed important question with the social considerations. We will discuss that later, I guess. So now we will listen to Professor Jorge Khalil. He is a professor of immunology and allergy at the University of Sao Paulo in Brazil. So the floor is yours, Professor Khalil.
I'm from Brazil. I'm Jorge Khalil. I'm a professor at the University of Sao Paulo. I think that how we are following this disease and how we're sequencing and what are the results that we get were very well presented by my colleague, Professor Esther Sabino. And so I decided to show you a little bit what we're trying to do to understand the variants of concern, how they escape from neutralizing antibodies, and how important it is. We have a variant that you know, that's the Pu1, that's causing disease now in Brazil. It's the most relevant strain nowadays in Brazil, and it provides a very bad disease. the transmission, the morbidity and lethality of these P1 is very high. We are living a very special moment in Brazil, and we decided to do so one of approach. I thought in the beginning that it's going to present our data on vaccines, but since for this session, I chose part of our work on trying to understand the neutralizing antibodies to these variants and how it could be important for understanding what's going on in different countries. So the problem is those variants, the P1 and P2 from Brazil, and then the B1351V1 from South Africa. And as you know, the important variants, the important mutations are located in these rose region here. That's the RBD. So in the RBD, we have several mutations, and what's very interesting genetically is that they are convergent mutation. That means in different parts of the world, we got the same mutation. So that shows very clear that the virus has a great advantage for these mutations. And these mutations are the ones that are responsible for dropping titers in neutralizing antibodies. And the one that is common to all three variants is the E484K. That means a change at the position 484 of the spike protein from a glutamic acid to a lysine. So, but this mutation could not account for the drop in the neutralizing titers, as you can see here. So you can see here the wild type has no drop, and then the British and Danish mutations have some drop in the neutralization titers. But when you look at Brazilian, there is a 10 times drop in neutralization titers. And when you look at the different South Africans, there is a 30 to 40 drop in neutralizing titers. This could account for why, for instance, AstraZeneca vaccine just protects 20% in South African. So the question is, so 484 is common to all, but there is a difference between P1, P2, and the South African variants in the drop in this immunization. So we address a question, if the 417 mutation, where in the African you have a change from lysine to asparagine in the position 417, while in Brazilian P1 you have a mutation from lysine to threonine. Could be account for this difference that you can see. So what we have done, so that's the difference between these strains causing such difference in neutralization titers, since all three present the E484 mutation. So this is the paper that we have submitted, and the first author is Katie Santos, my assistant. And so what we have done, we have synthesized overlapping peptides for RBD and try to get linear epitopes. You know that most of the epitopes could be conformational, but what we could see is that the most important epitope recognized by the high neutralizing IgG titers and high IgA titers for neutralization is the one that we call P54. So P54 account for 78% recognition by IgG and 84 by IgA antibodies from 87 individuals that we have tested. And this peptide encompasses hotspot site mutation with the 417 position, that is this mutation that occurs exactly here. So this is the peptide, and here is where the mutation occurs. So when we did an ELISA against this particular peptide, you can see that high neutralizer have a very high recognition for IgG and also for IgA, and there is a good correlation for both IgG and IgA in the recognition of this particular peptide. And when we look at the conformation of these, the peptide, the position 484, where one of the mutations occur, and then we look at 417, we can see when you have the mutation from glutamic acid to lysine in 484, there's a very strong difference, as you can see here and here. So a monoclonal antibody could not recognize anymore that particular position. And so this would account why many of the antibodies that are neutralized and recognize that particular area, they could not recognize anymore. But we paradoxically, the K417 was not that changed when we looked from one mutation to the other, when we changed from lysine to threonine. So apparently there's no mutation. But then when we look the surface structure with all the charges, and we can see that this is the how it recognizes, the antibody recognizes RBD for the ancestral and also for P1. But then, so P1 is very similar. We have a very similar mutation for B135. But the point is that when you add for B135 at the position 417, the asparagine, you create a site of glycosylation that you can see here. And you can see that it's here, there is a very strong binding. And here, apparently, there is a break in this binding because of this glycosylation. So what we can say from what we have seen, that the B44 encompasses hotspot region present in different strains, and this is particular for 417. The first linear epitope of RBD, it correlates with neutralizing titers or results of consistent with immune pressure on 417 region influencing mutation selections. And the presence of asparagine in South African strain could explain difference with P1 variant and elucidate a novel escape from the immune system. Thank you.
Thank you very much, Professor Khalil. It was very interesting, and I'm sure there are many questions. Just a summary of what I have understood from all this presentation. I see the sequencing platform is quite critical for this, for the identification, for follow-up, for the monitoring of this SARS-CoV-2 infection. And for me, I do. Maybe Professor Machel, do you want to have a comment? For me, the first question would be the challenges for all of you in low and middle-income countries. What are the challenges and lessons learned, you know, for the monitoring of the infection when I see the different experiences? So maybe if you have one comment, and then I will let the floor to Prof. Machel. So I don't know, the first one, maybe Dr. Sabino. That's correct, sorry. Yeah, Dr. Sabino, yeah. Mm-hmm.
Yeah, unfortunately, I think in Brazil, we are living a unique political organization. The response is really disorganized. So I think at the current epidemic, the most key thing is that we didn't have a centralized and uniform response. That was very different, for example, from the HIV, where the program was much more organized and we had the scientists together. So this is really, like, the scientists are not put together. It's really, I think this was the problem in this epidemic, this current epidemic.
Thank you, Professor Happy. What are the, yeah.
I think the major challenge here would be supply chain. So we can do a lot, but I think supply chain is a big challenge, especially in Africa. So how do you ensure constant supply chain in an environment where there's competition for reagents and resources? And this brings me to the point whereby I'm saying I think it's very important to Africa, for instance, to start thinking about how do you want to produce these reagents, because that is a big problem. We have the capacity to do this. We're well integrated with the public health system in the case of Nigeria, and then also through the Africa CDC. We see that integration in Africa, but I think our major problem is absolutely the supply chain and sustained supply chain.
Thank you. Docteur Baril, pour vous, quels ont été les challenges ou les leçons, les points importants des leçons tirées de la réponse à cette épidémie de SARS-CoV-2 COVID-19?
Oui, donc nous, exactement comme notre collègue africain, on est un pays où rien n'est produit, donc on a eu beaucoup de mal à s'approvisionner. Après, pour la question du séquençage, je pense qu'on avait pris l'habitude d'envoyer à l'extérieur pour les séquençages et on s'est aperçu que c'était absolument impossible d'envoyer en dehors des frontières et donc c'est là qu'on a commencé à se mobiliser pour s'équiper et maintenant on s'aperçoit qu'on a vraiment, on parlait de formation, éducation, on a un problème de capabilities, comme disent les anglo-saxons actuellement et on essaye vraiment voilà, c'est un des objectifs principaux. Voilà, on peut avoir des gros équipements, mais si on n'a pas les réactifs, comment on fait? Et on vit ça depuis le mois de février en permanence. C'est pas très facile de rester agile comme institution, en fait.
Merci beaucoup, Dr. Baril. Professeur Khalil?
Well, as Esther, I think, had already approached the problem that we have in Brazil, but I think that if we don't have a central coordination of all actions against COVID, and so the governors and the presidents were in different positions, different destinations, I would say, and for this reason, I think that we cannot control. We started late diagnosing the disease, and we don't have a coordinated way of doing all this sequencing in order to understand the advance of the disease in Brazil. Now, the main problem nowadays is getting enough vaccines to vaccinate the entire population. And actually, it's very important to know, and Dr. Sabin, who is helping us a lot, is trying to understand if these vaccines can protect us from the different variants that circulate in Brazil. That's a big issue.
Thank you. Professor Machel, maybe?
Yes, I have one specific question for Esther Sabino, because Manaus is 4 hours flight distance from Sao Paulo. As you know, Brazil is a subcontinent. And what's the explanation? Because this Manaus variant or Amazon variant, P1, now is the prevalent variant in Sao Paulo. Maybe because, you know, they bring the patients when the situation in Manaus was very difficult. They bring the patients to Sao Paulo, but I don't think so, because, you know, the patients are in the hospital. So do you have any explanation for this rapid transmission of P1 in Sao Paulo?
So I think the main thing is the transportation. So the P1 was detected in January, but probably starting November in Manaus. So we had more than 120 travelers from Manaus all over the country, but mainly to São Paulo. São Paulo is the center airport. So most epidemics will increase rapidly in São Paulo. I think that was the reason. It went unnoticed until we detected the first virus. So I think when the patients were transported, the epidemic had already started in many regions of Brazil. That's why it's so important to be able to detect the new variants as soon as they appear. So you can try to make something on those regions, because if you wait, when you detect, it's already spread everywhere.
Thank you.
For all of you, what are a question from a participant? What are the remaining gaps in transmission research that particularly need to be addressed for this and future pandemics? I don't know if someone wants to respond or we do a tour. So let's start by Professor Khalil.
Yes, sure. So I think that we have to create a system, a network of people, researchers that we do have in Brazil, in order to do a surveillance of the possible epidemics. On these, I mean, looking for that, there was recently created Institute All for Health, that I am the CEO, and we're going to organize and try to interact with different researchers and Brazilian institutions in order to have a whole system to the surveillance, not only for virus coming from abroad, but also coming from the Amazon region, that we know that we do have many viruses that could be a threat to human health.
Thank you very much. Docteur Baril, pour vous, quels sont les gaps qui restent en recherche, au regard de la transmission? Quelles sont les questions de recherche qui devraient être posées, et pour aussi assister à répondre aux futures épidémies?
Je crois que nous, comme ici en Asie du Sud-Est, on est un peu à l'épicentre. Il y a encore des choses qu'on pourrait essayer de comprendre et qui ont été déjà évoquées par le collègue coréen sur est-ce qu'il y a déjà essayer de faire une surveillance au niveau meilleure au niveau des gens qui travaillent, par exemple, près des chauves-souris, ou essayer de consolider ça. Et nous, on n'a pas réussi à répondre à la question, par exemple, d'une immunité ou pas, parce qu'on n'a pas eu l'autorisation d'aller explorer plus les personnes qui vivent dans ces zones d'interaction très fragiles. J'imagine que c'est la même chose pour le bassin amazonien ou certaines parties de l'Afrique. Et puis, il y a une chose vraiment importante qui manque pour nous, et c'est pour ça que des initiatives, je trouve, comme a fait l'African CDC ou EDCTP en Afrique, c'est d'avoir une meilleure régionalisation et pouvoir échanger les idées et les données sur un système de plateforme régionale. Ça nous manque beaucoup pour aller assez vite dans certaines alertes qu'on a. Et c'est quelque chose qu'on pourrait peut-être renforcer grâce à l'ASEAN dans les mois qui viennent, s'il y a une volonté régionale de faire ça à travers les pays.
Merci beaucoup, Laurence. Absolument, je pense que ça, c'est quelque chose de tellement important. And Professor Happy, for Africa, I see in Nigeria you are doing a great job. That's fantastic, but you know that's not the reality for most of the African countries. So for you, what would be the remaining research questions that need to be addressed?
Yeah, Francine, I do think that, as Odo said, that it is very important for Africa to set up a network, and which the Africa CDC is already setting up. While we are doing a fantastic work in Nigeria, we are also supporting through the Pathogen Genomic Initiative that you are very much aware in Africa, supporting other African countries. For instance, we have helped Cameroon sequence their samples. We are helping Somali. We're helping many African countries to sequence their samples. I think it's leveraging is all becoming important. So, and as we are leveraging as a continent, we should come up with a platform that will help to provide, to share information. I think why the world and many places in the world are struggling with pandemic response is the fact that we are very slow in our, first of all, ability to detect, and we're also very slow in our ability to transmit information to those that are making policies. And also, we're also very slow, in order to to come together as a group and as a global community. There are very silos. I think many silos around, and I think there's a need to actually share. We are very happy now that we have like a GISEP, which is a platform where people can make information, but at continental level, we should be able to have a surveillance system that is not only focusing on human, but is also very important to bring on board, animal surveillance, so that we can create an ecosystem where we are doing genomic surveillance at all levels. Because as you can see today, the two things that are very critical to contain either an outbreak, an epidemic, or a pandemic are first the speed of execution, that is speed to detect and then speed to response. So we do not have that yet, and then we also need the second thing, it is the accuracy which we detect all this information, we get all this information, and then the accuracy to respond. So speed and accuracy are those two things that we need at all levels: detection, and then the level of connecting this information to public health system, and also how the public health system respond. Those are the things that I feel are the gaps, and that's why we come up with this platform called Sentinel. That was even before COVID, before COVID-19. But we actually set up this platform because we are having gone through different epidemics in Africa, Ebola, Lassa, and others. We felt that those were the two things that we felt that are very critical, and that social platforms are very important. Thank you.
Thank you very much. Professor Matchel, if you want to.
Yes, I have a question from the audience for Professor Khalil, from Francis Ndungo. So, Professor Khalil, you are optimistic that COVID-19 vaccines will sort out the COVID-19 pandemic, given your data with the new variants versus the original virus?
Well, thank you for the question. Well, I do think that the vaccines were going to help us a lot and will control the pandemic. I think that in this beginning, the vaccines cover just the primary virus that changed a lot, and probably we still have some disease that will come because they are going to overcome the immune system. But new vaccines are being made that will cover, I would say, that the three main variants that we can see. And actually, when you look at RBD, the RBD is not that big, and we don't have space for too many variants to occur, and that will have a better fitness for the virus. So I'm pretty sure that very, very soon, with all these sequencing that we're doing, we're going to identify the most important variants in the RBD, and this will make us to do vaccines that will cover all the different variants, and we're going to control completely disease. In this beginning, perhaps we'll have still cases because the vaccine do not cover all the different types.
And regarding, the cellular response, because, much of the focus is making vaccines, but my question is another immune responses for the virus attack. Could you speculate on that?
Yes, sure. So from the early beginning, we thought that looking at the RBD or the spike protein and looking at the different algorithms to define the possible T-cell epitopes, we could see that there is a limit number of T-cell epitopes in these areas. So this could account for a lesser immune response and also not providing a good cytotoxic T-cell responses. So in what we are doing, the vaccine that we are developing in our lab, we have identified by different means a spectrum of 20 amino acids to cover CD4 and CD8 responses and to cover the entire population. That's what we are doing. I know that other people probably are doing the same. So I think that the next generation vaccines will not only intend to have a good humoral responses with neutralizing antibodies, but also a T-cell response. And concerning T-cell response, I think they are really very important. There is another paper that we just wrote on twins that have were discordant, and we have seen that the discordant on getting infected, and we could see that the T-cell response of both were completely different, although there were twins. But that's a long story. I can send the papers.
Yes, actually, one of the attendees is asking about, the reference of the papers you present. As you mentioned that the paper was submitted, maybe you can write,
Okay, but yeah, I can send because they already published these MedBricks. Yeah.
Okay, Francine.
Just one participant, how do you ensure sustainability of the different activities? I think maybe it goes to Cambodia and all of you, by the way, to ensure sustainability of sequencing, biobanking, all your activities. So if maybe this has to be linked to partnerships also. So maybe we start with, let's start Christian Rapi, and then Dr. Laurence Baril, and then Brazil, Dr. Sobino or Professor Halil. So how do you
I do think that sustainability will have to come to integration and to what I call integrating, first of all of these tools that we're developing in the public health system, so that at least they can appreciate, the value, and then that's how they buy in, and then they ensure that, this continues. But sustainability will also come through collaboration, because it's through collaboration that, resources can be shared, and we can actually make progress together. I think I believe in those two mechanisms, because once you want governments, which are actually leading and responsible for public health response, and for pandemic response to buy-in, these governments are the ones that form the international global, and then also from the global public health response community. So once they all buy into it, then I think this could be sustainable. Thank you.
Thank you. Dr. Baril, comment la pérennité des activités de recherche que vous conduisez actuellement, tout ce séquençage et biobanque, comment vous assurez cette pérennisation et quels sont en lien avec vos partenariats aussi, évidemment.
Donc, évidemment, on s'est retrouvés très isolés, c'est ce que je disais par rapport à des façons de travailler où d'habitude c'est très facile d'envoyer. Nous, on est tout près, on a 1 heure d'avion de beaucoup de capitales, mais néanmoins, on ne pouvait pas y avoir accès. Donc, on a dû faire des priorités. Donc, seulement depuis 3-4 mois, on arrive à reprendre certaines activités. On avait décidé de garder certaines activités clés pour les arbovirus, les virus respiratoires, la rage. D'autres ont été ralentis. Dans le reste de l'Institut, on a pu maintenir. Ce qu'on a demandé aux équipes, c'est toujours prioriser la virologie au niveau des techniciens supérieurs, parce qu'on a besoin de gens aussi qui puissent s'occuper des équipes. On travaille 7 jours sur 7 depuis 1 an. Et parfois, on ouvre le laboratoire de virologie 20 heures par jour. Donc, voilà, il a fallu demander de l'aide, et ça a été surtout de l'aide en interne. Le Cambodge n'a pas beaucoup d'instituts de recherche qui ont pu, par exemple, venir nous aider. Ça, on n'a pas pu le faire. Par contre, on a demandé de l'aide. On a eu 2 seniors qui sont arrivés de l'extérieur sur d'autres projets et qui ont un peu soulagé certaines activités. Mais c'est très, très dur, et je suis très admirative de nos équipes. Franchement, ils ont fait un travail exceptionnel.
You are mute. Sorry, Francine, you are mute.
Mute. Oh, sorry. Dr. Sabino and Professor Halil. Alors, how for Brazil, because the system was so disorganized, are you ensuring sustainability? Where funds are coming from partnership, and how do you do for thinking ahead and in this current situation? Thank you.
So I think it's key, this international collaboration, and when we get local resources with international, this stabilize the research groups in the long term, also make everything much faster to respond. And at the same time, you create the link between one country and the other. So I think it's key and important to have this kind of 2 countries or 3 countries or whatever in this early phase of the development of a program. And also, when we develop, we need to develop things that are easy
for the routine surveillance system in place to improve their capacities. So I think the two things together are key for getting a better, more sustainable way of responding to epidemics. Jorge, Caio?
Thank you, Esther. Well, what concerns research, I would say that we have a foundation in the state of São Paulo that supports research and gives a lot of support to many of the groups working in São Paulo for doing what Esther was doing, what I am doing, many other research groups. In terms of the Brazilian federal government, as you said, the Minister of Health was not very helpful. But on the other hand, the Minister of Science and Technology, with much less money, created what they call the virus network, where people were invited to participate, people that were involved in genomics, in in vaccines, in diagnosis, in different treatments. And this ministry has been very supportive of the activities of Brazil, although perhaps not enough for the size of the country. That's it.
Oh, thank you very much. I don't know, Professor Machel, do you have a participant's question? Or?
As my colleagues mentioned, the problem is the president. Because, you know, he's taking an approach against science and trying to demoralize WHO and international organizations, and many of the governors are acting on the contrary. So there is a lot of discussion, and there's even people against vaccination. So the problem is more political than related to resources. We have a lot of good examples in the past, as for example, HIV, the response to HIV, that was very much coordinated, and our vaccine program that used to be one of the best of the world. And even more recently about the Zika response was very good. In my opinion, the problem is more political. And so I think the international pressure, and everybody responds to international pressure. And so very recently, the president was pressured, and so he changed a little bit. Meetings like this are important for the international community understand that the problem is more related to political reasons than, you know, and so I'm very happy to participate in this meeting, you know, to for the people outside Brazil become aware that the scientific community is responding pretty well in terms of production of vaccines and sequencing of the virus. Okay. Sorry, my political comment, but you know, it's impossible not to do so. So in the actual situation.
That's very important, Professor Machel. And personally, I'm quite impressed in such environment to produce so important findings. And yeah, I think, yeah, we really need to benefit of your lessons, by the way. That's very, very important, to work in hostile environment and to produce high quality science. That's very important. And so from the last round of question would be, yeah, not political consideration, but linked to that, social and ethical consideration. Do you for doing this sequence, to establishing this sequencing platform, for doing these seroprevalence studies, for trying to follow, monitoring the spread of the infection. Did you face any social or ethical challenges that we would like to share with the participants? So I don't know, we start, if someone wants to respond, or we do a tour. So let's start by Dr. Baril, maybe. And,
oui, donc nous, on n'a pas pu faire certaines études qu'on avait prévues et qui étaient financées. Le comité national d'éthique nous a dit qu'il fallait attendre l'avis d'un comité interministériel. Évidemment, on n'a pas eu de réponse. Donc voilà, on a été bloqué. Pour d'autres choses, au contraire, on a eu du soutien. Et dans l'ensemble, le gouvernement a beaucoup soutenu, via le ministère de la Santé, qui est une de nos tutelles, l'Institut Pasteur du Cambodge. Donc dans l'ensemble, on a fait pas mal de choses, mais pas tout. Et on ne sait toujours pas pourquoi on n'a pas pu avoir certaines études qui paraissaient assez simples d'autoriser. Voilà. Mais on avance quand même.
Merci beaucoup. Professor Happy, Nigeria is big.
No, we didn't. Yeah, we didn't face those challenges because, for pandemic response, we're working directly with public health authorities. And then the same for samples that we're getting from across Africa, that's from the Africa Center for Disease Controls and the governments involved. I think so far we have really not faced any ethical and then what we call ethical and then social-legal challenges. Over.
But just sorry to ask you that, but with this new variant, because I know that here in Congo, when you pronounce variant, people are afraid by this word. So when you say that, okay, you have identified a new variant and so on, the population, was not worried. It was, you didn't have any problem to explain, no?
Of course that people ask questions, but I think in our own case, what went well was the fact that there was a lot of talk already in the UK. You know how Nigeria is linked to the UK. So many people were aware of variants already in Europe and then in America. So by the time when we were discovering our own variants of concern, they knew that variants are things that that exist. But what is also good within what we're doing is often that our informations are given directly to the public health authority and they know how to frame the message. So when they frame the message, of course, you're going to be having an uproar, you're going to have people asking a lot of questions. But the fact that we know, and that there was education prior to us that, variants are, of course, are expected. We prepare people already to know that because of travels between Nigeria and then outside the country is a major hub of travel, that we definitely cannot escape, the emergence or the import of variant in the country. So that kind of prepared the minds of people, and that wasn't really surprising when people heard that there were the UK variant in Nigeria, then also the Nigerian variant itself emerging. So I think in a way it wasn't too challenging because there was some level of expectation of that already.
Great. For Brazil, do you have it?
I think the problem of getting approval is always delay, and I think we need to standardize how approvals need to be done when you are under an epidemic for certain studies. Also, I think it's important to define what are the key studies. You can't do all the studies. So you need to put some studies and prioritize the resources to those studies instead of competing. So the delay in having the idea and receiving the resources are key for a project to happen. So we need to improve these. Most of these things needs to be thought between the epidemics and be organized before you have because it's too hard during an epidemic that you control everything, and in general, this end up in a delay of everything. So planning before what are the key research that we need and how we're gonna deliver the resources is important.
Thank you very much. Professor Machel, do you have any further?
Yeah, yesterday one of the chairs, since we are approaching the end of our session, so he asked the participants to have, you know, one wish, one beautiful wish, you know, to gain, to win, you know, this fight against COVID-19. From all the speakers, starting from you, Francine.
Oh, oh my God. For me, my wish would.
As a chair, you can be the last, okay?
Okay, thank you.
Okay. So we're starting with my Brazilian friends, Khalil and Esther.
Okay, so I think that everybody in the world, what they are wishing to have is a good vaccine. I think everybody had their arms ready to expose for a big needle to inject a good vaccine. So I think that's what we are missing. And I think that's, I would like to wish to everybody to have a vaccine, a good vaccination, and perhaps we'll need a second generation in the future to completely put under control this disease. That's what I would like to wish to everyone.
Esther?
As Khalil has my wish also, the second one would be to have really a better network that we could detect earlier, and we have everything in position to respond to a new epidemic.
Christian?
Yeah, I think it's important. Vaccine is going to be important, but I think we need to keep emphasizing the need for respecting public health safety measures, you know, despite the vaccine, that should remain important. But then most importantly, collaboration and the support of those countries that are endowed support those that are not, so that everybody in the end can get vaccinated. Because it is obvious that a country that has, you can spile up 10 times the doses of your population. But the reality remains that as long as certain areas in the world keep struggling and battling with this pandemic, then you are not safe. I think there's a need to have an international cooperation and then international support for one another.
Thank you. Laurence?
Yes, so I will answer in English. So for me, it's vaccine first everywhere. I mean, we are a less advanced country, so we can see how slow it is, even the effort of the government here. It's starting, but it will be slow. And of course, a collaborative mindset and collaborative network. You know, I felt that we were very alone for some part of the response at the very beginning, and this is why I admire again the effort on the African continent and all what has been done in Africa. We need to. It's a good model for everyone, including in country in Asia.
Thank you, Francine.
Oh, thank you. That's good to be the last. I understand completely what has been said by the others. That's great. Thank you very much. You also, Machel.
Yeah, I think international cooperation, besides vaccination, and I agree with the other measures as masks and it's important also. So, Francine, I think we can finish our session, giving the podium to the closing session. And so, please, I'd like to thank very much, you know, our speakers. It was a very good session. I learned a lot. And please, Francine, close the session. And thank you for your cooperation also.
Thank you very much, Professor Machel, and thank you very much all the presenters. You have done very great presentations. I've also learned a lot. I'm really impressed by the work that you are doing, honestly, fantastic. And I'm sure your wishing list is quite, yeah, we need to stick to that, and hopefully, yeah, we will finish with this, and we will be ready for the next pandemic. Okay, so thank you very much. Thank you, and happy Easter to, yeah, to everyone. Thank you. Merci à tout le monde.
Thank you. Merci.
Et on laisse la place à la session suivante, so the place to the next session.
Merci, Francine. Thank you. My name is Marta Tufet, and I'm the Executive Director of the UK Collaborative on Development Research, or UKCDR, as we like to call it. UKCDR is one of the co-hosting organizations of this meeting, alongside our two partners, GloPID-R and the COVID-19 Clinical Research Coalition. And it's my real pleasure to be chairing today's final and closing session, which we hope is going to bring together the discussions that we have had over the past couple of days to achieve the aims that we set out to achieve with this meeting. And I thought that perhaps I might start by reminding ourselves what those aims were, because we have brought here researchers and funders together with a very specific agenda. We were hoping to discuss emerging research findings, any ongoing research activity on COVID-19 across low and middle income countries. We also wanted to identify important obstacles, including persistent research system gaps, as well as both unmet and emerging research priorities for COVID-19, specifically in low and middle income countries. And importantly, we want to identify what had worked and how to enable cross-setting learning for ongoing response and future research preparedness for epidemics. This session itself will comprise three parts. First of all, we will hear about the results of the learning survey, which we circulated ahead of the meeting in multiple languages, and hopefully some of you had the opportunity to complete. Then we will hear from the co-chairs of each of the preceding sessions, and they have been given the opportunity to summarize the findings of their sessions into sort of a few key messages. And then finally, we will hear some closing remarks and next steps by each of the co-hosting organizations, including myself for UKCDR. So without further ado, I will now give the floor to Sheila Mburu, who's a Research and Policy Officer at UKCDR, and she's going to present to us the results of the learning survey. Over to you, Sheila.
Great, thank you, Marta. And as Marta mentioned, and as many of you would have seen, we've been undertaking a survey both ahead of this meeting and during, to try and understand some of the barriers and enablers that as researchers you've been experiencing in undertaking COVID-19 research in low and middle income countries. Next slide, please. So in the survey, we are specifically for barriers and enablers to undertaking research framed around the COVID Circle 7 funder principles for supporting high quality research in epidemics and pandemics, with a focus on low and middle income countries. And what we really wanted to understand is how the funding response and the broader research system has impacted or supported researchers' ability to fulfill these principles. Just to mention, as the survey is still open and it's ongoing, these are very early stage findings. So they're just the themes that are emerging from the survey so far, but we thought it would be helpful to share with this meeting to help guide further discussions. So in terms of the biggest barriers identified through the survey, the first was around the ability to identify sufficient funding and capacity to undertake rapid research, particularly in the early stages of the pandemic. Another barrier was around opportunities and avenues for collaboration and coordination with other researchers working on COVID-19 research focused on low middle income countries. There was also an indication that it was difficult to form and sustain equitable research partnerships. And then lastly, another big barrier was around understanding and aligning to global research agendas, but actually more specifically, the challenge highlighted was around locally defined research priorities and being able to identify those. Next slide, please. We also asked researchers to identify enablers of research which helped them to fulfill some of these principles. And as I mentioned, these are emerging findings. But one of the enablers around understanding and aligning global research agendas was the availability of a global research agenda. So the WHO research roadmap, for example. But respondents highlighted that it was difficult to find or more difficult to find locally defined research priorities. The second enabler around ensuring rapid research was the use and existence of local or national research funding or the reallocation of existing research funding, which facilitated rapid research to take place in the early stages of the outbreak. But some respondents also highlighted the benefit of the rapid research response calls that were issued. Pre-existing partnerships and relationships were highlighted as being really important for supporting the building and sustaining of equitable research partnerships, which really highlights the benefit of funding longer-term partnership for epidemics preparedness and future response. The existence of pre-existing database and data sharing platforms was highlighted as an enabler to supporting access to data and data sharing. But again, more generally, access to data and data sharing also came up as a challenge. Next slide, please. In terms of preventing the risk of harm and undertaking research, the availability of ethics guidance, safety protocols, and PPE was highlighted as a key enabler. Rapid ethics review processes where COVID-specific projects were expedited, or the setup of COVID review panels, again, were highlighted as enablers for supporting the ethical review and approval processes. And then lastly, the existence of pre-existing relationships and networking opportunities and tools were highlighted as facilitating collaboration and coordination with other researchers working on COVID-19 in low resource settings. Next slide, please. And so that was just to give you a sense of the emerging findings. We're really keen to continue to capture your perspectives as researchers on the barriers and enablers to undertaking research in low resource settings. And so the survey is still live and available, as Marta mentioned, in English, French, Spanish, and Portuguese. And it's really important because we hope that the results from this and also from this meeting will enable us to capture some lessons learned and recommendations to inform future funding and research response for future epidemics and pandemics. Next slide, please. And just to say many thanks to our funding partners, but I'll hand back over to you, Marta, for the next part of the discussion.
Great, thanks, Sheila, and thanks for giving us a snapshot and a brief insight into those early emerging findings. And so please, I would encourage everyone who has a couple of minutes to take the time to fill in the survey, because we will be using this to inform our future work in this area and to link up to the funders. So next, I'm going to invite the nominated co-chairs of each of the 4 sessions that we had over the past couple of days to synthesize 4 key findings from their session, and particularly to highlight one learning output. They'll have 5 minutes each to do this. I believe that the first nominated co-chair is Professor Nick White, who's going to be summarizing the findings of the clinical research session. Over to you, Nick.
Thank you very much, Marta. So on behalf of my co-chair, Jean-Marie Habarugira, and our speakers, these were our thoughts. I won't take too long. In principle, we felt we should descend from the high-level comfort of generalities to the less comfortable ground level specifics. So although clinical research is, we've heard a lot about coordination, the fact is it's still very fragmented. Too many small studies with different designs which cannot be pooled and don't result in actionable things that benefit or can be translated into policies or practice. Bottom-up research partnerships work, but the obstacles to doing this are very many, and much of this is of our own making. Process, bureaucracy, slow from the very beginning of the research applications, or even the call through to the getting permissions to actually do the work. It all takes far too long in a pandemic where every day is measured in hundreds of deaths. Nevertheless, political and financial support can enable good research in low resource settings. There is an enthusiasm and an appetite and a capability. It needs to be strengthened, but it can be done. So it is really worth supporting the research that you've been discussing over this past 2 days. A specific point on data sharing, which we've heard a lot about, there isn't enough of it. It's not easy, actually. It's difficult to persuade people to share their data for very good reasons. And if you do share your data, it requires quite a lot of work and management. So that really does need to be supported as an integral part of clinical research support. So finally, I'm sorry, we were greedy. We took 5 of the 4 options. So there are, as we've all heard repeatedly, the COVID-19 problems that either affect low resource settings predominantly or are simply uncharacterized in low resource settings, such as emerging virus mutations. We've just heard about that. The implication of that is that we think all clinical research support funding should also fund biobanking so that there is intelligence on the emergence of relevant virus mutations. Many of us believe that the mortality in low resource settings is substantially underestimated. I don't mean just the direct mortality, but as we've heard in this meeting eloquently described, the excess mortality because of the damage to the health system. That needs to be measured so that funding, both for research and funding from governments and international donors, can be appropriately apportioned. We've heard a lot about the post-COVID condition in wealthier countries, but we really don't know how much it affects lower resource settings. And this is not an exclusive list, by the way, but we believe that falsified medicines, particularly falsified vaccines, are going to specifically affect low resource settings. Just heard of the fake Pfizer vaccine in Mexico. This is likely to be a substantial threat. So let's actually try and answer these problems. Let's address them and get that research done. And our message, our learning, which seems to have disappeared from the bottom of the slide, very simple. Our cross-cutting message is listen to the voices on the ground. Listen to the people who are working with COVID, managing COVID, preventing COVID, and researching COVID. That's where the directions will come from. I'll finish there. Thank you.
Thanks very much, Nick. I'm pleased to say that the message was not cut out from your slide. We can see it very well and we can hear it loud and clear. Listen to the voices on the ground. And hopefully this meeting is just the start of that conversation, and we will continue to do that, to listen from all of you here participating and who've got very sort of real practical experience of dealing with this pandemic on the ground. Thank you, Nick. I'll now move on to invite Dr. Moses Zalobo, who's going to be presenting on behalf of the health system session. Moses, are you ready?
Yes, I am. Thank you. Thank you so much, Marta. During the health systems and indirect health impacts of public health interventions discussion, my co-chair was Dr. Patricia Garcia, and we got really good presentations from Sabina Faiz Rashid, Queen Dube, Yapbom, and Massimo Ghidinelli. And out of the discussions that came, including participation from the audiences, here is a summary of some of the things that came out. So it was quite clear that we need to consider vulnerability assessments and community engagement from catchment areas of public health initiatives for COVID-19, and also make sure that whatever the population is using for determining the appropriate health-seeking behavior is also taken into account. And we thought that we could create and support resilient health research systems that can take into consideration the social determinants of health and also build into the proposed interventions the vulnerabilities that the communities are facing to be identified. And then we said that there is need to diversify the research approaches needed to take into account the realities of low and middle income countries by providing for equitable distribution of support for the diversified research approaches, focusing on areas of exposure for global public health, and those are stress on, for example, increased investment in diagnostic and surveillance laboratories, and this has also come out in the session just before this closing session. And then we said that it is important to integrate vertical programs, not just delivery programs, but also research programs for COVID-19 with other programs like TB, malaria, HIV, maternal and neonatal child health, non-communicable diseases, while at the same time recognizing that there is not enough data and therefore there's a need for building data for the rebound health indicators. At an instance, we were shown that for TB, for example, we are 10 years behind. We've regressed by 10 years. So therefore, there's a need to invest in the drivers of integration for the proposed interventions, factoring in rapid results catch-up phase for the lagging indicators. So research needs to be focused on that. And then also integration should be from all the way from the top, from the policymaker to the frontline worker, and not just at the bottom, for example. And then we said that we also need to consider a systems approach for the health system support, including, of course, service delivery, human resource management, financing, information and communication technology, medicines and technologies, and leadership and governance. And how do we do this? By promoting primary healthcare, including implementation research, having increased investments in the areas that I've just mentioned, but also focusing on human resource management, the skills, the training, the delivery for frontline workers, especially community healthcare workers, for the simple reason that there's a possibility that the disease might be around for quite a while. And then in terms of our cross-cutting learning, we discussed and agreed that there is need to work with a sense of urgency, not just for the imminent issues that are currently facing the world, but also deliver an upgrade for health systems that goes beyond the current epidemic. Thank you so much.
Thank you, Moses. That was clear, and thank you so much for providing some actionable next steps and very important cross-cutting learning here that we've heard throughout the whole meeting about the need to upgrade health systems and use the current pandemic and as an opportunity to build back better and to strengthen the health system across a range of diseases, not just in relation to this current pandemic. Right, so I would now like to invite Professor Uma Ramakrishna, who's going to be giving us the key messages from the One Health session. Over to you, Uma.
Thank you, and thanks everyone for listening. I'm happy to present these on behalf of myself and co-chair Dr. Chung Min. So, the One Health session was exciting and interesting. I think One Health is something which everyone looks forward to in the future. but I think some issues came up and I'd like to highlight them here. I think speakers highlighted that it's quite critical that both research and capacity building be considered when starting on or embarking on One Health approaches. One of the talks focused on actually and highlighted the importance of insightful research, novel bioinformatics and evolutionary biology to suggest potential viruses which may spill over. There was a strong emphasis on partnerships and that and a realization that even before we talk about a collaborative, intersectorial, interdisciplinary approaches such as One Health, having these partnerships and collaborations in place is critical to the success, more than the location where you may want to have a One Health approach. Partnerships that will enable such an approach are really critical. Finally, there was a very important point on continued monitoring and ongoing One Health frameworks and research, which is very strongly contingent on funding. When you have something like an outbreak or a pandemic, the need for funding and the need for action is very evident. But surveillance, monitoring, and these kinds of activities are often harder to have sustained funding for and sustained effort for. So overall, there was a feeling, of course, that One Health is a great approach, but I think most importantly, it requires significant understanding between the collaborative parties and significant and dedicated long-term funding. So I think that this is something which I hope that given the kind of renewed push for international collaboration and data sharing and working together, let's not even say any of the other things, and learning from each other, which we've heard about from all the sessions. I hope that such approaches can be extended in the context of One Health, and hopefully this will help us in the future to avoid situations like the one we are in today. Thank you.
Thanks very much, Uma, and for bringing back that notion of collaboration. I would like to emphasize there that when we talk about collaboration, particularly in the One Health approach, it's important to consider not only collaboration between researchers, but between funders, recognizing that funders often will often have a health approach or an animal health approach, but not necessarily both of those. And so I think coordination and collaboration at the level of funders is equally as important as at the level of the researchers. Thanks very much, Uma. So I'd now like to invite our last session representative. I believe it's going to be Rui Maciel who's going to presenting on the final outputs. Professor Maciel, are you available? Thank you.
Thank you very much. The session was very much interesting. And I would summarize that, there is a necessity of central coordination between in the several countries. For example, the research community respond quickly, but the government did not. So it's very important to have a necessity of central coordination in the several countries. Secondly, the animal surveillance and seroprevalence studies in rural and most deserved populations are very important, for us to understand and to attack the problem. The networks must be strengthened. There are many works related to data sharing, and this is very important. And the data sharing, must be very rapid to promote, initiatives. And and monitoring infection and vaccination, and increasing sequence platforms in low and middle income countries are very necessary. We have very good examples, for example, in data presented today in Brazil and Nigeria, between others. No? And the crossing cutting learning is the Africa's collaborative all for Africa approach. And at the end, I ask, one wish from all participants, and what is important is vaccination and international collaboration, and I believe international pressure on the governments, for them to be prepared not only for this pandemic but for the future pandemics that will come. Thank you, Marta.
Thank you very much, Ray, and thank you also for bringing that political lens. I think far too often we have seen a mismatch sometimes between that political will and the research, and sometimes it can be facilitating, but sometimes it can be a barrier. And so it's something that we have to engage multiple disciplines, not just biomedical scientists, but political scientists, economists, social scientists, and anthropologists to help us understand those interactions as well. Right, so I'd like to thank you all for co-chairing those really insightful sessions and providing a very concise summaries. I know it's not hard to summarize these rich discussions into just a few points to draw the lessons learned, to understand what the persistent research gaps, and to understand priorities. We thought what it would be helpful to do now is to move on to the 3 co-hosting organizations to provide some final remarks and some reflections on the past 2 days. And importantly, I'd encourage everyone to think about actionable next steps. For those who've joined now, just a reminder to speak slowly and to use regular pauses for the benefit of our interpreters. With that, I will invite Professor Charles Wisonga, who's going to be representing GloPID-R, to introduce himself and to offer his remarks. Over to you, Charles.
Thank you so much, Marta, and thank you to everybody for this very exciting 2 days that we've had. And on the South Africa, I work for the South African Medical Research Council, which is a funder, which are part of the GloPID-R. And this meeting has been an important event to identify gaps, needs, and current and future research priorities relevant to low and middle income countries, the LMICs, which will inform funders on how they could try to address these issues. So let me talk a bit about the South African Medical Research Council and how we responded in terms of funding, and then some remarks on behalf of GloPID-R. So South Africa is an example of an LMIC that has a strong commitment to funding and supporting science in the face of the health, social, and economic impact of COVID-19. The South African Medical Research Council rapidly put together and funded a rapid research strategy for the country. There has been no doubt in our situation that resources have followed success. And whilst we were fortunate to be able to mobilize resources for research early on, it was the value of the work which has led to later mobilization of resources. So this tells us that while funding is important, researchers are also important, and the researchers and the funders need to work together. It has been critical to success that we have been able to respond to COVID-19 from a platform of investment in science and innovation and building the capacity of scientists to do this research. We can only respond to immediate crisis if we have laid the foundation of the response over the longer term. We have a great deal of South African investigator-initiated research, but also research that has drawn on the power of long-standing international collaborations, particularly partnerships that were built for addressing the HIV pandemic. And during these 2 days, for those who were not aware of GloPID-R, you've learned that GloPID-R is a network of funding organizations investing in infectious diseases, research, preparedness, and response. And low and middle income countries are a top priority for GloPID-R for COVID research, as well as research capacity on any pathogen with epidemic or pandemic potential. And we've learned all through the discussions and also from the comments from the co-chairs that there's a need for global solidarity in the research response. We heard yesterday from the director of the Africa CDC that COVID-19 has made us as humanity to realize how connected we are, but it has also exposed inequities in research and inequities in access and utilization of resources, utilization of health services. So there is a need to strengthen capacity between epidemics and pandemics, the importance of networking and cross-disciplinary work. The many examples of successful research contributions to policy have been given by the various speakers and through the various sessions. GloPID-R, and I am very sure that this extends to the other two partners in this meeting, will ensure that there will be a follow-up of activities addressing the identified gaps and opportunities for stronger collaboration. This meeting provided an opportunity to engage with research opportunities and research funders across the Global South at a time when at GloPID-R, we want to embark on a drive to extend the membership of GloPID-R in the Global South. The outcomes of this meeting will surely contribute to GloPID-R's current review process, as was presented yesterday by our chair, on the research needs and priorities over the next 18 months. And I only want to wish everybody great success, and it is important that we do not only end with the great ideas, the great discussions that have come up out of this meeting. We need now to start implementing this, because it's only from the actions that these 2 days will be meaningful. Thank you so much.
Very many thanks, Char. I would like now to give the floor to Professor Helen Rees, who's going to be representing the COVID-19 Clinical Research Coalition, who is one of the 3 co-hosting organizations. Helen, please take some time to introduce yourself and then provide your remarks.
Thank you very much. So my name is Helen Rees. I'm based in Johannesburg, where I head a large research institute here, and also the Drug Regulatory Authority. And I've heard quite a lot of comments about regulators in these few days, but I also work very closely with various structures on WHO and Gavi and CEPI. But importantly for this, I'm very pleased to say I'm part of the Clinical Research Coalition. And I just want to recognize Nick White and Patty Garcia and Francine and Tumi and various others who are on this, who are part of that coalition. I wonder if, I just got a couple of slides that I want to put up, and I wonder if you could just take my screen. So my first punt to everybody is to say, for everyone who's still managed to stay on, please join us, either as an individual or an organization. Because the louder our voices are, the better we will be able to achieve some of our ambitions. One of the things, oops, where have I lost my slides? One of the things I just wanted to start with was something that happened today that really, I think, places us in a strong position if the world can pull this off. And this is the proposal from 20 global leaders from a range of economic background countries, suggesting that we should have a global pandemic treaty to dispel temptations of isolationism and nationalism and address challenges that we can only achieve together, as Charles just said. This is very important. So far, the US, Russia, and China haven't joined in. I guess this is early days, but I would suggest that one of the most important things we can do in terms of the research that needs to be done in LMICs is to really hang on to this thought that the world is now moving to a new treaty if they pull it off. And this treaty is going to be something that they say is going to be akin to post a Second World War type treaty. So we've heard a lot about what we've learned, but I'm just reminding us a little bit of where we came from. There was a huge imbalance before COVID between rich and poor countries in terms of who's publishing, whose names are on papers. There was a whole range of partnerships and coalitions, from the very good and very collaborative through to, unfortunately, still what we call safari research, and inadequate funding into LMIC networks. And very poor funding, particularly, we've heard something different from Charles, but inadequate funding often from governments themselves in these settings because of opportunity costs and prioritization. Poor research infrastructure, and particularly difficult in many of our settings is to retain younger and older researchers who want to go off to places where resources are better. Fragile health systems we've heard a lot about, but also weak laboratory and surveillance capacity. So we've learned a lot, and just to sort of just underline what I've heard from absolutely fascinating discussions, the importance of speed and preparedness. From that last discussion, we had the absolute importance of national leadership at all levels, but also political leadership. It's not only about funding, it's about what the framework is in which we want to work, and belief in science. So I think that is something that we have to now also push and support. We've learned about the importance of surveillance and the importance of innovation in that. Very impressive has been the genomic surveillance and the spread that we saw, the numbers of labs in the African region, to where we have rapidly grown in terms of ability to do surveillance, including really innovative mapping of what is happening. As Nick said, that one of the reasons for doing this is the epidemiology varies. And unless we get a handle on all countries, things like the emergence of variants, the pressure on the virus to change is going to continue. A global sample and data sharing, incredibly important. And even today, I was in a dialogue with one country where we're trying to share samples, and they have massive regulatory obstruction to being able to export samples. And then partnerships, and we haven't necessarily mentioned perhaps enough of this, but the health services themselves are really important. The data they are collecting, that data, feeding it through to epidemiologists and to the laboratories, and triangulation, and the role of modeling so that we actually start to understand where we are. Research agility, and we've heard this ability to flip has been incredibly impressive, and the readiness to do this. But I'm just adding another word, which is leapfrogging. I said concertinaing, I don't know if that's a word, the clinical trial process. We need to be able to move very rapidly, which we've done, particularly in terms of vaccines, with large, well-designed studies, but being able to consolidate and change the way we normally do business, using virtual platforms instead of paper platforms. But also just to remind ourselves that some of the research that has needed to be done was on some of the non-pharmaceutical measures. What is a good mask? What is a good way in a low resource setting to administer oxygen? What are the socio-behavioral lessons that we need to learn? And what are the innovations for lower resource settings? Research partnerships, many people have already spoken about, but that's incredibly important. That's why we would encourage you to join the coalition. And by the way, we're welcoming people from North and South. This isn't just for people in LMICs. Regulatory alignment, as I said, is proving to be, on the one hand, that we've made strides. On the other hand, it still is a barrier. And then incredibly importantly, funding, rapid access, and what do we need to do in the future to have a button that we can press to get funds when we see even sub-regional or regional outbreaks. It's not just the pandemics that we need to be able to respond to. And how do we get national governments to understand the importance of investment and what is going to happen? And this is why this voice of this conference is so important to global funding investment. And what's the role of the private sector? Is that a group that we haven't yet tapped upon? So with that, I just want two last points. The importance of community engagement CSOs and activism. We've seen that this has been so important, for example, in the world of HIV/AIDS research, in terms of access and research mobilization. Can we actually tap into that, and have we paid enough attention to that as we rush to try and get our research agendas off the ground? This is something else that we should think about. And I'm just going to leave you with one quote, and I'm not sure to whom it is attributable, but it goes, "It is because we are poor, we cannot afford not to do research." So I'll just leave you with that, that thought. But I would like very much to thank the organizers. I think this has been excellent. It started an important dialogue. Thank you very much.
Thanks very much, Helen, and thank you for reminding us how far we have come along as well. I think it's often easy to focus on what the challenges are, but it's good to recognize as well how far we've come. And also for highlighting other sectors that we have perhaps not represented or engaged with as much, whether it be the private sector or civil society. Right, so I would like to now provide my reflections as the third co-hosting organization, UKCDR. For those of you who joined now, my name is Marta Tufet. I'm the Executive Director of UKCDR. And I'd like to thank Charles and Helen for providing the remarks, but also for the coalitions that they both represent, for partnering with us at UKCDR on the occasion of this meeting. For those of you who are perhaps less familiar with UKCDR, we are a collaborative of UK research funders that are interested in international development. So this includes the 3 UK government departments, the UK research councils that fall under the UKRI banner, as well as the Wellcome Trust. And our aim is to ensure that there's strategic coherence across our members to ensure that we are ultimately maximizing the impact of their collective investments. And so we do this through a multitude of ways. We bring the UK funders together around themes of interest, including meetings like the one we've held today and yesterday, which also bring the research community together with the funders. And the deliberations of this meeting will feed into the funders in our collaborative to help inform their decision-making in relation to the current response, but also in relation to the future. At UKCDR, we also aim to generate best practice for funders in the sector. Professor Peter Piot, our outgoing chair, already mentioned in the opening remarks the joint principles that we developed to support funders strengthen their research response in relation to current pandemic, but future epidemics and pandemics. And so these principles aim to guide funders by making sure that their research investments in and within low and middle income countries are guided by best practice. So for example, by ensuring that research is aligned to local needs, that it is context specific, that funders are also strengthening capacity, a running theme that we've heard throughout the past couple of days, but also that they are promoting equitable partnerships. The funders also have a role to play here in developing calls and facilitating that. We know that equitable partnerships take time and effort, and we've heard in the last couple of days that a lot of the successes have been based on existing infrastructure. And then other principles that it's important for funders to adhere to include supporting open access, giving adequate consideration to ethical aspects, and importantly, that the funders themselves are also coordinating in collaboration. So in addition to bringing funders together, in addition to generating best practice, we also provide data analysis. So providing visibility on what funder is doing what where, to help funders understand how best they can direct their investments within a wider landscape, and thinking about how their particular agendas can complement other agendas towards a common goal. And an example of this was presented by Alice Norton and Emilia Antonio and my team yesterday on our work on the COVID-19 research tracker. So this is a living database that is now tracking COVID-19 research investments across 130 different funders. We have over 9,000 projects now that have been classified against the globally identified R&D priorities of the WHO, and we're in the process of classifying these against the UN R&D recovery priorities. And this is supplemented by a living mapping review that we are updating quarterly, and the latest version will be published this week. So, do follow us on social media or join our newsletter to get updates on that. But an important point is that we know and we understand that priorities evolve over time, and that global priorities don't necessarily address local or context-specific challenges, which is why the deliberations of this meeting, as well as the results of the learning survey, are incredibly helpful in us informing funders on where the persisting needs are, what the emerging needs are. Many of the priorities that were set up at the start of the pandemic have completely shifted. We didn't necessarily know about long COVID. We didn't know about the variants. So it's incredibly helpful for us to understand the learning, the evolving landscape, but also importantly, what's working, what are the enablers, what's not working, what are the barriers. As we know that this pandemic is not the first one, and it will certainly not be the last one. So we really need to learn so we can strengthen future responses. As an organization that brings together funders, I can't avoid mentioning money. And there is no doubt that the impact that COVID-19 is having on the economy is felt across every single sector. In the UK, the research for international development sector, which had experienced a period of significant growth over the past year, has been significantly impacted. And so in the face of diminishing resources at UKCDR, we feel it's even more important now than ever to have a better understanding of what the research needs are in low and middle income countries, so that we can provide funders with the best available evidence to make informed decisions. When it comes to the needs of low and middle income countries, it is your contributions that are most valuable. So thank you again for participating in this meeting. And I want to emphasize, to end by emphasizing that this is by no means the end of a conversation. We want to continue hearing from all of you so that we can strengthen the current and future responses. Thank you. Right, so with the remarks from the three co-hosting organizations, from GloPID-R, from the Clinical Research Coalition, and from us at UKCDR, this now concludes the final session. I would like to thank all of the speakers of the session before I move on to the closing remarks. Thank you. Okay, so I hope that you have found the meeting useful. I certainly have. I would like to thank you all, the chairs, the speakers, the participants that have stayed with us for so long, for all of your rich contributions, and for your engagement in this important meeting. A few housekeeping points. The recordings of the meetings will be available on the three co-hosting organization websites, which you can see on the slide there. Do watch out for these, or join our newsletters or mailing list, or join us on social media to get the latest updates. The learning survey that my colleague Sheila Bora presented on will still be open after the meeting for a week, and we would encourage those who haven't filled it to do so. It is available in the 4 languages of the meeting, in English, in Spanish, in French, and Portuguese. And in addition, as soon as the meeting closes, you will also automatically be redirected to a meeting feedback survey. We'd love to hear your thoughts, and it should only take a few minutes to complete at most, and it's important for us to understand how we can improve these meetings in the future. Finally, I would like to offer a vote of thanks to the meeting organizing committee, to everyone from GloPID-R, from DNDi, from UKCDR, who's been working behind the scenes, and with a special thanks to Rachel Miles, our COVID Circle Program Manager at UKCDR, who has been working relentlessly over the past few months to make this meeting a success. Right, with these final remarks, I close our meeting on COVID-19 research in low and middle income countries. Muchas gracias a todos. Merci beaucoup a tous. Obrigada a todos. Thank you and goodbye.